And we're now recording. All right, here we go. What I'd like you to do is take a moment on your notepad or paper somewhere and just write a question you have about dyslexia, something that was a burning question that you had coming into today. Because what I'd love to see is by the end of the day, that question's been answered. And if not, let me know. Okay. So just take a moment to write down the question. And I'm getting a message from one of the participants. Okay. All right. So I'd like you to kind of make note to self and answer these questions for me. True or false? Dyslexia can be cured. We're going to come back to this slide a little later. So I want you to write your answers down and then we'll check them later. Dyslexia can be outgrown. Dyslexia is a neurobiological condition or a language processing disorder. So think of it this way. Before you answer this question, I would like you to think about the dyslexia fonts, the rose-colored glasses, the skipping lines, letters falling off the page, words moving around. I want you to think about that in context to this question. The lived experience or the patient or the client's history is important when it comes to assessing and treating dyslexia. And there are different types of dyslexia. All righty. Did you know that 80% of children with a specific learning disability, they are dyslexic? So this is really interesting, especially now that our main group here is a school district. A large percentage of your caseload, I'm anticipating, has a diagnosis of a specific learning disability. So let's say, just for the sake of numbers, that's 100 of your clients, 100 of your students, 80 of them most likely have dyslexia. But I'm anticipating 80 of them do not have that documented that they have dyslexia in their file. And because of that, we may not be treating their needs to address dyslexia. So when you think about dyslexia being a prevalence rate of 1 in 5, we're probably missing a lot of opportunity to support these children. Children with reading difficulties also struggle with emotional issues such as anxiety, depression, low self-esteem. There's a very high suicide rate with young adults and individuals with dyslexia as well, especially if you're not reading by the third or fourth grade. Yep, that's exactly what I just said. I jumped ahead. So typically, if a child is not reading by the third grade, it's usually that they are 4 times as likely to drop out of high school. And so when we think about from a revenue standpoint, and when we think about schools that get paid for children or students being in seat, and we have all this dropout, we have the dropout rate in high school. If we kept them in seat, there would be some revenue there to provide that support in the earlier years of their education to address the dyslexia and the reading issues and everything else that's going on, and hopefully prevent them from dropping out of high school. This is an old statistic, but still very relevant and current, and that is 60 to 80% of welfare to work adults have dyslexia. And this is just a fun fact that I keep in here because I thought it was interesting. So dyslexia is more prevalent in girls than boys. All right. So I'd like to take a moment. Thank you for sharing with me the discipline that you're representing. And I'd like to take a moment to kind of share my story because it'll give context to what you're about to learn today. I grew up and early in elementary, was having difficulties with school, and I failed 6th grade, but they just ended up passing me anyway. And then because I had technically failed 6th grade, but was pushed on, they went ahead and put me in special ed for the remainder of middle school. And I went to school in New Jersey. And then when I was a junior in high school, we moved to California. And the reason why that is relevant is because California had different requirements for education standards than New Jersey. And I was now in a situation where I had to pass a math sufficiency test to graduate from high school. So in my junior year, I failed that test and was at risk for not graduating high school. And because of the school I went to was so small and remote, they didn't have special ed at the time. So they moved me to a 7th grade math class. I'm a senior in high school at this point. They moved me into 7th grade math so I could pass the test. And I did eventually pass and graduate. I went on to junior college and I failed my first year of college. And from that point, I joined the military. And the deal I made with myself was, if I didn't finish college by the time I finished the military, I would enlist for life, because I knew I had to do something to support myself, but I didn't really know how to get there. So the year my enlistment was up, I completed my bachelor's degree. And during this time, I had decided I was going to go to school to become an OT. I applied to Loma Linda University and I wasn't accepted because of my grades. They were so low. So they asked me if I wanted to go into their OTA program. So I was accepted into their OTA program and I graduated from the OTA program and immediately applied to the bachelor's OT program and got accepted. But then I was recalled to Desert Storm and was gone for 7 months. And when I came back, I failed that following semester. So once again, I failed out of school. So I just went on, and that's when I completed my bachelor's somewhere else. And I went on and got my master's later on, and then went on with life. I was practicing as an OTA. I was enjoying it and decided I wanted to be a mom. So I went ahead and had my daughter, and she was my only child. And as an occupational therapist, I was the perfect mom. And I say that tongue in cheek. And I know that OTs out there are probably kind of grinning because you know what I'm talking about. I'm thinking, oh, I know all the sensory stuff. And, I'm going to make sure we're signing when she's born, and we're going to play and get her feet in the mud and her fingers in the finger paint. And we're just going to do all these sensory things and give her these rich learning experiences. So imagine my surprise when we get to kindergarten and her teacher shares with me that she's struggling with sight words and I may want to study with her. And I'm thinking, wow, we already study 2 hours a night and she's 5. And I thought, that's a lot. And it wasn't resonating with me at the time that there were all these signs that there were things going on and things I should have been noticing, because in my mind, she was my only child and I knew she wasn't at the top of the learning curve, but I didn't care because I was thinking she's still learning and growing and doing fine and she'll go at her own pace. And I was totally okay with that. By the time I got to 3rd grade, we really saw some significant struggles and I couldn't just dismiss it anymore. And so we took her out of state and got her tested, and she was diagnosed with dyslexia. And then they tested me and I was diagnosed as well. And when I was diagnosed, I thought, well, that explains a whole lot of things that went on. And when she was diagnosed, I was just so grateful for a diagnosis because I thought, hey, we can get her some help. And so I went back home to get her help, and we enrolled in all these after school reading programs, and none of them had permanent change. None of them gave permanent long-term success. And I increasingly became frustrated because I was looking at the school to support her reading and learning, and it wasn't working out. And I couldn't quite figure out the missing piece. And then I had an epiphany and I thought, you know what? If that's how I practiced in terms of my clients didn't have long lasting results, I wouldn't be a therapist for very long and I wouldn't be able to keep a job. So what's going on? And that's when I took my head out of the dyslexia realm and I looked at it differently, because my background up to that point was with traumatic brain injury. And when I got my master's degree, that's what my research was involved with. So I thought, okay, she has a brain. What do I know about the brain? And I know that when there's a neural pathway that's damaged or not working, it will often you can often find a different pathway to get there. So could we do that with somebody who had dyslexia? So I looked at it from the perspective of, what if she came to me as a client with a traumatic brain injury? What would I do? I would test all her executive cognitive functions. And that's not something we do with individuals that come with us with dyslexia, because we think it's a reading issue. So that's when I saw a lot of glitches, and I worked with her and saw improvement. And I would share my story with other people, and they'd bring their kids to me. And that was the spark behind Dyslexia Center of Tulsa. And I had that private practice clinic for about 12 years. And about a year and a half ago, I sold the clinic, and I sold it. It's in great hands with a company who also has a pediatric clinic. So it's a great marriage and services. And now I created Dyslexia RX to address more of the mental health services. But the reason I shared this journey with you is I wanted to let you know that throughout the day, you will hear anecdotal stories from my own experience, being a mom of a child with dyslexia, my daughter's experience, and I do have her permission to share. And you'll hear my clinical experience of working with individuals and families with dyslexia, as well as evidence-based research. I will always tell you if something is just my opinion. I'll tell you if it's evidence-based. I'll tell you if it's clinical experience, because I want you to be able to pick and choose the golden nuggets that work for you, and what doesn't work for you, you can just leave that behind. So thank you for being here and for letting me share my story. I'm just going to check the chat really quick to make sure I am not missing anything. Okay, great question by Hannah. What are some of the best strategies to support reading at home? Hannah, we provided you with a list of strategies in your attachments, and we will also go over them. So that's to come later today after lunch. If I'm still not getting to your question, or you still have questions about that, let me know and I can expand on that. Let me see if there's any other questions. I think that was the only question. Great. Okay. And that's how it'll go. As I see questions come in the chat, I'll stop every once in a while. Okay. So as I said, I went to Loma Linda University and earned my doctorate degree. And I did a small qualitative research study with about 14 participants, ages 12 to 50. The main question I asked was, what was it like to live with dyslexia? And we came out with 3 themes. One was the story of my life, how they perceived other people perceive them, how it impacted their roles and occupations or activities that they do to occupy their time throughout the day, and just that all over grit. And so Candy was a preteen. And when you think about the story of my life, when she reflects on how people perceived her, she said, it makes me feel like I'm worthless, like people think I'm worthless. And I have seen that theme pretty consistently in servicing children with dyslexia, and it just always breaks my heart. And then let's see if I can expand this. Hang on. Oh, there we go. Yeah. Then when you think about grit, Candy says, I shouldn't give up on what I want to do. And so when I think about grit, I think about that marriage between perseverance and resiliency, and how it threads through our life and the choices we make. I think the most profound story that I heard of one of my research participants was a mom who had 2 young children who were in elementary school. And if you've had children, you may have experienced, you get permission slips sent home to go on a field trip, and you sign them and send them back to school. So she was sharing with me something similar about that. And she said that her children, she sent them off on the bus to go to school for their field trip. But when she went to go pick them up at the bus stop at the end of the day, they weren't there. And she was really worried about them and couldn't find them. And she ended up calling the police to file a missing child's report. And then several hours later, she gets a call from the school letting her know the children just got back from their field trip. And I think most of us at that moment, if that happened to us, could empathize, that relief of, oh, whew, the kids are okay, or, oh, I feel so dumb, or I can't believe I forgot that, or, whatever it is. But she had a very different reaction. And what she ended up doing was she had reached out to relinquish custody for her children because she thought she wasn't competent enough to care for them well. And from my experience, it takes a lot to get a person to that point. This isn't just a 1-point event where you just make that decision. And so I'm really curious what trauma that she as a mom had lived with growing up with dyslexia that led her to that point, and that this was a really eye-opening glimpse into the impact of dyslexia on a lived experience, that dyslexia is not about reading, it's about our life and everything that goes into our life, and to consider that. So it was just a real powerful moment. After I did the interview process with the individuals who lived with dyslexia, I went ahead and I reached out to other people who had dyslexia. These are not the same people that participated in the survey. And I asked them, what's it like to live with dyslexia? So I did a short excerpt in this video that you're about to see. And at the beginning of the video, you are going to see me just asking random people, what's dyslexia, and what their answer is. And then you'll hear me sit down and visit with people who have lived with dyslexia. What I would like you to do is just make note of things that make you go, wow, that's interesting, or And after this video, we're going to talk about that a little bit. So I'll go ahead and start it.
I believe dyslexia is where people get words mixed up.
Dyslexia is a learning disorder where when kids look at the paper, they don't see what we see.
And I think it does go over to piano. I teach piano and things will get muddled. So something's going on up there.
I don't really know exactly how to explain it. I guess that would be another good definition for dyslexia. It's really hard to explain.
As far as I know, it's when you mix up words or you can't really, the beginning and the end of the words switch in your mind, and it's hard to form them.
Yeah, I feel like teachers get very irritated with her because she requires more time from them than the other children in her class. If she doesn't feel comfortable with something, if she doesn't catch on to it real quick, she won't want to try it at all. And then like with the basketball, with the coach getting loud with her because she's not catching on to the other girls, that makes her break down and cry. And then she's embarrassed that everybody's looking at her, and he's like, why is Mackenzie crying? And it makes her even more upset when he's
sometimes not even wanting to go to school, telling your mom or your dad, or crying to them, saying, I can't do this. Saying, I can't do what all the others are doing. Makes me sad.
We're not against.
It's very hard. Oh, I'm sorry. You're away. I'm sorry.
Oh, I knew this was gonna bring up a lot. And the car, she was so emotional. I'm like, why are you so emotional? I didn't know you had all these feelings. Are you okay?
I'm just telling my friends. It's kind of them half the time. Saying I'm not like you. I'm different.
I didn't know it was that big of a deal. I'm sorry.
It's not. It's just I don't know how to handle it. It doesn't. When I try to, it just seems to sort of not want to work with me.
Oh, gosh, I didn't know that. I was asking about dyslexia. What does it mean to you in the car? And she got really emotional. I thought, well, where did that come from? I'm sorry, sweetheart.
The bullying is, it's bad. And any child that goes home and cries after school, those scars, they're deep.
Well, during school, like 2 days before the last day of school, we were doing some sort of quiz, and it got to me, and we were going around the room, and it came upon a question about George Washington, and I was thinking, and the teacher said, "The next person," and I don't know what came over me, but I stood up and I said, will you stop? I understand what's happening here. You don't want to give me a second to think about what I can do. I can do it if you just give me a second to think about it. Everyone in class just sort of looked at me. And at that point, I was like, my confidence sort of left and said, and I was like, oh, I'm standing up, embarrassing myself. That night, I went home and I said, I know what I did. And I stood up for myself. And how many 5 years of not wanting to say anything, I stood up for myself and said something about it. And I felt happy. And I went outside and screamed, I know something. I could do something. I'm normal. And it's always been there for me. And I now know that
I thought if
I
you
am
were always a good soldier and always tried, everything worked out. I wanted to be in TV news. I got a job in TV news, and suddenly 2009 and the economy happened. I think for somebody who is dyslexic to suddenly go, whoa, I have to reinvent myself completely was really difficult for me.
Okay. I know that can be hard to watch. I still get all the feels watching that, the empathy of people having to go through those experiences. So as we reflect on what we heard, what I'd love for you to do, put in the Q&A, I'd like to know from you, when we were asking people in the park, what is dyslexia? What did you hear them say? If you'll share that in the Q&A. And then while you're sharing that, the other question I have is, when you were listening to the people who lived with dyslexia, what resonated with you? What did you hear them say? If you'll share your thoughts in the Q&A. Eva, that was really interesting, your comment. That always gets me too. There's a difference in the brain. The music teacher, I thought her insight was really interesting. People in the park, confusion and stereotypes. Yes, Hannah, not easily defined. Roxanne, I chuckle about that one every time I hear it, because when he says, I don't know what dyslexia is, maybe that ought to be the definition. Yeah, I liked that answer. So yes. It was a reading thing and it's hard to explain. Yes. Not easily defined. Very good. Yes. All of you are right. So what did you not hear them say? The people that lived with dyslexia, did you think there was something interesting that you expected them to say, but they didn't say? I'll give you just a minute on that one. All right. Well, you're thinking of that. Let me just kind of pose a few things here for you. The people in the park were sharing that dyslexia is where you mix up letters and words. We're not really sure what it is. And how do you feel about this statement? That is probably what most people think of dyslexia. I think that's a pretty common opinion about what dyslexia is. I heard that it's difficult for people to explain, expecting them to say flipping letters. Yes. And they blame them, and the people living with it blame themselves. Yes. It didn't say anything about their strengths. That's very interesting, Margaret. Yes. And so the people who shared what it was like to live with dyslexia, they never talked about the services they received. They never talked about the reading instruction that they received and how that impacted their life and how it changed them. What they talked about was the psychosocial impact of dyslexia. They talked about feeling that people don't think they're capable. Think of what Kamari said. She's like telling the teacher, just give me a chance. Just give me a minute. I'll get there. And so there's this gap between what society thinks dyslexia is and what we're taught dyslexia is. We are taught that dyslexia is about reading. But people that live with dyslexia have a very different understanding of dyslexia, and they will tell you about the psychosocial component of dyslexia. So when we think about client-centered services and we think about meeting our clients where they are, if we have a client that comes to us with dyslexia, and the first thing we do is we test their reading ability, and their reading ability is poor or lower than average, and we send them to tutorial for reading or reading remediation or tier 2, 3, 4 reading remediation or an after school program for reading, and we don't address those psychosocial components, are they really going to be open to receive the intervention? So think about that for a minute, and let's watch this next video. This next video, which some of you may have seen, it's a video by Brene Brown on empathy and sympathy.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I had a, yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. At least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So now think of it this way. We have one of our students come to us, or a client or a patient come to us, and they come to us because they have dyslexia. There are 6 steps to working with individuals with dyslexia. And that first one is meeting them where they are and asking them really interesting questions, such as, what is it like when you're asked to do, and then pose the question of something that they're struggling with. How do you feel? I can see this is hard for you. I feel your frustration. And just really addressing that psychosocial piece first is so important. You may miss the exact feeling they're having, but the fact that you're willing to reach out and have the conversation, you may be the first one to ever ask these questions in lieu of saying, just try harder. Let me explain it again. Let's go over it differently. It's not an issue of them being unable to learn, because those who have dyslexia do well in a million other things in their life. So it's not that they're struggling understanding what you're saying, or, saying it over is going to do better for them. It's an issue that there is a part of their brain that's not functioning at the rate of somebody that doesn't have dyslexia, and that needs to be strengthened. So until that happens, really having some empathy and acknowledging that psychosocial piece is really key. So what if we understood that executive cognitive function was required for reading? And what if we understood that there is a sequential order that executive cognitive function has to be built on for reading success? And what if we understood that if we addressed executive cognitive function, we may see some permanent change? And what if we really brought that telescope back, and in support of that psychosocial component, we addressed grit, growth mindset to empower children to have their own voice? And what if we took the medical model and we overlapped it with the educational model? So I want to pause here for a moment and expand on what I mean by that. Depending upon the setting you practice in, let me rephrase that. The setting you practice in sometimes will guide how you practice. So let's say, for example, you work in rehab. In fact, just the other day, I was at Shriners Children's Hospital in Sacramento, and there were children there who had traumatic brain injuries, gunshot wounds, CVAs, strokes, things of that nature. So there was definitely some cognitive impairment. If I was seeing a client in that situation and they struggled with reading instruction may not be the first thing I choose. I may decide to assess their memory, their visual perceptual skills, their processing skills, their problem solving skills, their reflexes, their ability to have those foundational skills to be able to function at that higher level of reading before I addressed reading. And if they scored below average or scored at a level where I was concerned, I would treat those areas first. And once those areas had met their best potential, then I would introduce something higher level, such as reading or reading skills. But if we're working in the school system and we see a child come to us with dyslexia, we're not thinking that they have issues with executive cognitive function. We're thinking they have issues with reading. So we're not even addressing those executive cognitive functions. So it doesn't even really click that, oh, let's peel that onion layer back and find out the why and address the why first. And that's really important, is if we take that concept from the medical model and we apply it to working with children who struggle with reading and have dyslexia or suspect have dyslexia, and we address those executive cognitive functions first, your outcomes will be much improved. As I said, that whole point of being able to see your client as a whole person, excuse me here for a minute, to be able to see your client as a whole person, address those psychosocial needs and everything else that goes along with their success. If you do that first, you will really be off to a good start. So I always like expanding on this point a little bit, especially when I'm working with a team that's in the school system. And most of you that are here today are working in the schools. And here's where this is a struggle. You have a large caseload. I mean, I'm anticipating you have quite a large caseload, and you have certain benchmarks you have to achieve by certain dates. A school year is a finite amount of time. You have initial evaluations to do, IEPs to do. You have certain milestones your students need to meet by the end of the school year. You may be, as an OTR, seeing the student once or twice a school year. An OTA may be providing the treatment. Teachers or a support team may be providing the treatment. You may not have the time or the luxury of saying, well, Dr. Stack, spending time on a psychosocial aspects, we don't have time to do. Well, that may or may not be true. You can always refer, though. You can refer to the counselor, you can refer to a support team. But I will tell you one thing that I know for a fact, and this is anecdotal experience and clinical experience where this comes from, and that is, if you make that connection, you build trust, you create that relationship, and that child believes in you, the confidence that'll grow and that'll extend beyond the time that you see them, because they will not be with you forever. They'll move on to another provider in a year or 2 years or 3. We'll keep them open to receive support from someone else. That in and of itself, even though it may not be a measurable milestone, is the most important thing you could ever do, versus having a child come in, getting right to what the task at hand and reading, and not making that connection with them. I had a first grader come to me and say, why am I here? This is just another thing that's not going to work. And that just broke my heart. And I thought, who broke this kiddo before they came to me? Why would they feel like this? And so somebody before that child came to me did not create that trust, that safe space, that relationship. So meeting them where they are is essential. And I am checking the Q&A. So if you have any questions along the way, please just drop a question in there. If I'm going too fast or anything comes up, let me know. All right. So we talked about grit. This is something I explored when I did my research and something that I incorporate when I work with children all the time. So 2 scenarios. And I think this came from the book I was reading on grit. And this is an example I read in the grit in the book. This isn't my own. This is not my own. This is not my own example. So you have a child that's on swim team and they're at a swim meet and they don't place. They get in the car and their dad's like, you were robbed. It wasn't your fault. You'll do better next time. Versus, hey, well, yeah, you didn't place today. If you want to swim because you just enjoy swimming and you're okay, this is great. If you would like to place, there are things you might be able to do. You may want to start going to practice more. You may want to start planning a strategy. It's empowering the child to take some ownership of their ability to improve. Is it a guarantee they're going to place? Absolutely not. Is it a guarantee that they'll improve? There's a pretty good chance they'll improve, versus it's someone else's fault that you didn't do what you didn't place. And so it's the difference between, that growth mindset, that fixed mindset, and building that grit, that it's something that they can do. Interesting story about my daughter that I like to share about this time. I think she was in high school. I want to say 10th or 11th grade. I can't remember, maybe 10th grade. And she had a paper to write and she turned in the paper, the draft, and it didn't have citations in it or references. And so the teacher asked her to go back and put them in. She came home and she was just kind of befuddled and started working on it about 4 o'clock. And I think she just had a couple of research articles, not many. Long story short, 10 o'clock at night, she is still working on this. And it was interesting because I could tell throughout the evening she was frustrated, and I never asked her to work on it. I never told her to do it. No one really made her do it. She had a choice, and the choice was, yeah, I'm not doing it. Whatever grade I get is the grade I get. I never asked her, and I still to this day have no idea what she got on that paper. What I can tell you for sure was the grade better than what she would have received? Probably. Did she pass that year of school? Yes. I'm curious to hear from you why I never asked about the grade. I'd love for you to put something in the Q&A and tell me why you think I never asked about the grade. And while you're thinking of that and putting that in the Q&A, I do want to share with you that I advocated for her in school ever since she was little. And it probably turned into a helicopter parent. I think I was too involved because I was trying to protect her. And we always talked about her grades and we always talked about her homework. And this was the one time I was intentional about not asking her. Any ideas why I did not ask her? Let's see what's in the Q&A. It places more importance on the grade than her effort. Yes, Roxanne, exactly. It places more. Yes, yes. Danette, to teach her that the effort was more important than the grade. Yes, exactly. Both of you are right. So what I was really doing was helping her build grit and teaching her a growth mindset. We have to teach our children these skills because eventually they will not be with us, whether it's our student or our own children. And so it's interesting because in high school, I remember one time she got a low grade. You know how you see it on the computer portal that you have access to? I called the school to ask about it, and they're like, oh, she's already come up to us, worked it out. We have a plan. That was the last time I ever asked about her grades. She's now in college. She's got great relationships with her teachers. Like, she's launched. She's able to navigate this by herself. Why? Because we've had opportunities like this in her younger years to build that grit and fixed mindset. So these are skills that should be taught and can be taught with children who have dyslexia. It's part of empowering them and giving them their voice. If you haven't read these books, they come from Dr. Duckworth and Dr. Dweck. I highly recommend them. I use them after I read them to just raise my daughter, no less, working with the children that I provide services with. They're a great resource. All right. So what is dyslexia? Dyslexia is real. And I say that because oftentimes we hear that dyslexia doesn't exist. They just need to work harder. I had a kindergarten teacher tell me one time that she's never worked with a child with dyslexia. And when you think of the prevalence rate of dyslexia being 1 in 5, what I realized was it's not that she had never worked with a student that had dyslexia. It was that she didn't understand how dyslexia presented at the age and grade level that she taught. And the fact that the students she worked with were engaged in a lot of play and hands-on activities, I could see why it may have been more challenging for her to see it. I've also worked with families where one parent swears that dyslexia is all made up and another parent that maybe has dyslexia that totally gets it. So it's really important to acknowledge that dyslexia is real. It's more than just letter reversals. Prevalence rates 1 in 5. Some prevalence rates say 1 in 10. This comes from Yale Center of Creativity, Dr. Sally Shaywitz, who's one of the leading researchers in dyslexia. All right. So speaking of Dr. Shaywitz, let's take a look at some of the research behind what's going on in the brain. Okay. So at the top here, this is a functional MRI, and a functional MRI, for those that may not know, is very much just like going through an MRI, but you are awake and you're engaged in activity at the time that they're doing it, and they're seeing what areas of your brain are activated in the activity that you're doing. So you can see here in the first image, this is somebody who does have dyslexia and very few areas of the brain are engaged. And the bottom image is somebody that does not have dyslexia. This is a typical neurodevelopment. And you can see the brain's firing a little bit more equally and engaging everything it needs to engage. Okay, so let's just take another look at this here. It's same image, just a different way of looking at it. So you'll see the image on the left. This is somebody who does not have dyslexia. You can see they have letter form recognition, Wernicke's area, and Broca motor. And then you see the brain image over here, and this is somebody that does have dyslexia. And there's a lot going on here, or should I say not going on. You can see that letter form recognition and Wernicke's area is not present. And you can see Broca motor's area is quite enlarged as compared to the image of somebody that does not have dyslexia. In the Q&A, can you share with me your thoughts on why you think that Broca motor is so enlarged here with somebody that has dyslexia versus somebody that does not? I'd love to hear your thoughts on why Broca motor is so enlarged. I'll just give you a moment to type that into the Q&A. Roxanne, yeah, I think you're close in the ballpark there. Roxanne says they are using what they can to access and using it heavily to figure it out. Yeah, I think that's about right. So let me explain to you what's going on here in the as far as how information comes in. So information comes in through our spinal cord and it goes into the brain. We recognize what it is that we're seeing or what we're understanding. We're interpreting it through Wernicke's area, and then we jump on the arcuate fiscus, the neural pathway that brings it over to Broca's motor, and this is how information comes out. Somebody who has dyslexia, information comes in, but there's no place for it to initially land. Letter form recognition either is underdeveloped or not developed. Wernicke's area is either underdeveloped or not developed. So it's just kind of sitting there. And Broca motor is over here and it's watching this information just kind of wander about and says, oh, wait, hey, I do language. Come on over here. Let me help you. So the information's like, phew, okay, thanks. I appreciate that. And the information hops on over to Broca motor and it just gets there. It's all comfy. It's like I'm in a safe place. And Broca motor says, oh, wait. Yeah, so here's the deal. I do language, but not that type of language. Let me see what I can do. So it's overworking and overcompensating. And when this happens, the person, information comes out incorrect, a little mixed up. They may have to go around the whole block to tell the story, or it may actually come out correct. So when you think about Kamari in the video, when the teacher asked her a question, and then the teacher assumed she didn't know it and wanted to move on. And Kamari said, wait, I know, just give me a minute. What was really happening in Kamari's brain is the information was sitting here in the great abyss, trying to find a place to latch onto. So when we're communicating with an individual that has dyslexia and they pause, let them have that moment to pause. When we, in all of our good nature, repeat the question, say it louder, explain it differently, we've just interrupted their process and now they have to start over. So really give them a good solid moment. The rule of thumb I tell people is wait to the point where you're uncomfortable, then count to 10, then go ahead and ask if it's okay to ask again. And asking it the same way probably isn't effective. You may want to show them or do it differently, and that'll most likely be effective. So essentially what's happening here, think about a Volkswagen Bug and an 18-wheeler. You have an 18-wheeler that's in New York and it needs to carry its load to California and it breaks down right at the Lincoln Tunnel. And Volkswagen Bug comes along and says, hey, I can carry that load for you. You know why? Because I have wheels and I have an engine and I do the same thing you do. I can transport. And so the 18-wheeler is like, hey, thanks. I appreciate the help. And so they unload that whole load onto the Volkswagen Bug. And the Volkswagen Bug says, okay, I'm getting ready to go. And it may make it 3 inches and break down. That's what's happening with Broca's motor. It's taking a load that it cannot work with. So yes, Danette, it's compensating. That's exactly what has happened here. All right. So this is just another way of looking at it. This slide does not cover the whole story I want to share with you. It's just a placeholder for me to share the story with you. So MIT did a research study years ago, I think. Yeah, it says 2016. This was the first study of its kind. And I loved it because it kind of picked up where Dr. Shaywitz left off. So Dr. Shaywitz, when she did her research, she focused on the here and now, what is happening in the brain right now. But with MIT, what they did, they looked at the long-lasting impact of language intervention for reading success. They worked with about middle-aged adults, and they had 3 groups. They had a control group of individuals with dyslexia that did not receive information, a group with dyslexia that did get intervention, and a group with dyslexia that did not. So they had 3 different groups. And so the interesting outcome of this was they took a look and they did the intervention and they did functional MRIs and could see the brain firing while the intervention was going on, and they were doing really well. Then the intervention was completed and a significant amount of time passed. And then they did MRIs again on the people who had dyslexia and had the intervention. And what they noticed was their MRIs looked just like the original MRIs, meaning all that activity wasn't happening anymore. And so they thought, this is really interesting. Let's take this another step further and let's do the same methodology on children of emerging reading age. So these were young children. And what they found was the results were identical, meaning children and adults, so we can say individuals with dyslexia, had less neuroplasticity in the language processing areas of the brain than people without dyslexia. So what that means to us from a therapeutic and remediation standpoint is it is not impossible to remediate individuals with dyslexia. It just will take longer. And so once that reading intervention is gone, it tapers off. And the reason it tapers off is because there were no executive cognitive functions or foundational skills, if you will, or Velcro, or however you want to put that image in your brain for it to stick to. Why? Go back to Dr. Shawitz's research. The neural pathways either were underdeveloped or not developed. And until they are developed, it will not stick. It should be a big aha moment for reading specialists, dyslexia specialists, anybody that specifically works in the teaching aspect of reading, because I guarantee you've had experiences where you've had this great dyslexia program that's been successful with several children, but you get this one child and no matter what you do, it doesn't work. So you try another program, doesn't work, another program doesn't work. And you're scratching your head thinking, well, let me try this manipulative and this hands-on activity, and nothing is working. And you're thinking, what is going on? What is going on is they also have executive cognitive functions that aren't being addressed. Is dyslexia caused by executive cognitive function problems? No, it's a language processing disorder. However, if they have executive cognitive function issues, they must be addressed. So that is the missing piece here of treating dyslexia, and that's what we're focusing on in today's workshop. All right, so we have different types of dyslexia. We have developmental dyslexia. This is the type of dyslexia where somebody is born with it. It's genetic. There is somebody in their family who also has difficulty in reading, whether it's a parent, a grandparent, an aunt or uncle. Oftentimes you don't know this because they're not maybe diagnosed, but this may be somebody who really didn't like school. Maybe they didn't go to college. Maybe they are very good at construction or art or music or something that is a very hands-on activity. Or maybe they went to college and they are at the top of their game because they worked so hard trying to learn what they learned that they are now the expert in that area, or they're an entrepreneur. There is a high percentage of entrepreneurs who have dyslexia. Prenatal care does not influence if your child will have dyslexia or not because it's genetic. It also transcends through ethnicity, geographical regions, mother's age. None of that has any impact on if your child will inherit dyslexia or not. And it can occur in any language. And this is really important because years ago, it was thought that dyslexia does not happen in languages that are symbolic, but research now shows that it can. So that's really important. And learning a second language can be really difficult for people who have dyslexia. And when you have ESL, which is something we run into a lot in California, unless you have testing for dyslexia in their native language, it's going to be really hard to know if it is a language barrier or dyslexia unless you're looking at anecdotal signs and characteristics. Then you have acquired dyslexia. Acquired dyslexia can be due to a trauma such as head injury, a stroke, things of that nature. Age and declining cognition such as Alzheimer's or dementia does not cause acquired dyslexia. I'm keeping an eye on the Q&A. So far, we're good. Okay. All right. Excuse me. So I receive a lot of questions about what are the signs and symptoms and characteristics of dyslexia? That is a tough question to answer because the list is broad, it's individually specific, and there isn't one list that gives you that answer. For example, when you have a bone fracture, you can clearly look in an x-ray and clearly see the bone has been fractured. And you can even tell what kind of fracture. Is it a compound fracture? Is it a hairline fracture? You can tell. It's an absolute. With dyslexia, it's not an absolute. So it takes a little bit of, connecting the dots or putting the puzzle pieces together, if you will. These are some of the things that are most common that you will hear. It's certainly not an extensive and complete list. Maybe difficulty with spelling, handwriting. They may not enjoy reading out loud. They may struggle with written comprehension. They know the correct answer. It's on the tip of their tongue, but they can't get it out. Hang on for a second. That they can't get it out. So it's not that these are the issues that you're looking for as much as the disconnect. And what I mean by that is just because you have poor spelling doesn't mean that you don't like reading out loud. And just because you may have struggles with reading, with word retrieval doesn't mean you have difficulty with handwriting. So it's when there's, at first glance, there's no connection and it seems random. That should be your first indication to take a deeper dive in the consideration of dyslexia. I want to show you a video here in just a minute, and this is going to be kind of a learning experience for us. I am not showing you this to teach you how to give this screening tool. I'm showing you this to hone in on observation skills. So this child that we're working with here is 7 years old. He's in first grade, 6 months, and we're working on the DSF, the dyslexia screener for first graders. And before we administer that test, this child has to meet some criteria. They have to write all their numbers and they have to write all their letters. And if they don't get 20 out of 26 correct, then I'm not supposed to administer the screener. But I did administer the screener anyway, because I just wanted to see what was going on. So what I'd like you to do is watch the video and then write down some of the takeaways. Just pretend that this student is in front of you and you're making your observation notes. I want you to write those down and also post in the Q&A what you're seeing, and then we're going to discuss it. Here we go. Now, before I start this video, because I already hear the wheels turning in the OTs that are here. This child does not have any neurological reason for this posture. Does not have cerebral palsy, does not have hypertonicity, nothing of that nature. So I just want to throw that out there. And again, write down your observations. Please place them in the Q&A. And here we go. Hang on. I need to give you some context here. I just realized that. So on this particular test, before this child got to the writing portion, they read a list of words and each list was a grade. So pre-K, kindergarten, first grade, second grade. And they kept reading until they got 50% or less correct. And that's where they stopped. At that grade level where they got at least 50% correct, I dictated to them 10 words that they were able to read correctly. And that's the list you see here on the left, that completed list of 10 words. I dictated the list that he could read correctly in the anticipation that he could spell them correctly. This is called eidetic, meaning he could remember how to spell them. Then of the lists he couldn't read moving forward, I dictated 10 words he could not read. This is the list you see him writing right now. On this list, this is the phonetic list. I want to see if he can spell phonetically. What is he hearing? What is he processing? And what is it coming out on paper? How is it coming out on paper? So we're going to see what he's able to write from the dictated words I'm giving him. Here we go.
Next. Father.
Okay, so if you will do me a favor and write in the chat the observations that you made. What are some things that you're concerned about? If this kiddo was in front of you, what would be a concern? Why is it a concern? What would you do? Would you pull further testing? Where would you go with this from a clinical reasoning standpoint? I'd love to hear you place this in the Q&A. This is a great opportunity for us to have a discussion and troubleshoot together and work on analyzing what we're seeing so we know what steps to take next. I'll give you a moment to write that in the Q&A. Okay, so think about it like this. Did anything jump out at you that you would have concerns about? When you watched him, maybe he heard the word, what did you see him do? And was it effective for him? What strategies did he use? Did he yield good results from that? What are some things that concern you? If you'll put those things in the chat, this is a really important piece of today for us to have this discussion to help build those clinical skills on how to analyze what's going on with the kiddo in front of you so you can create the best plan to support the child moving ahead. So whatever you wrote on your notes, if you'll put them in the Q&A for me, and then we'll pull them out and we'll go over them together as a group. Okay, we're starting to get some posts in the Q&A, so I'll just take the first one. So it could be concerned about auditory processing. Yeah, so Chris, great point. I would also be concerned about auditory processing, and I'm just going to go ahead and guess why you picked that up. Because let's say, for example, I said the word father, and he sounded it out, and he may have sounded out correctly, but he wrote different letters. So in order to be tested for auditory processing disorder, a couple of things here. It's very rare. It's typically the population of 2 to 3%. And if somebody has dyslexia, it goes up to a whopping 5%. So still very rare. And I use the SCAN-3 as an auditory processing screener. Of all the children I have sent to an audiologist, I've had maybe 2 or 3 come back with auditory processing disorder. It is very rare. However, always worth getting tested. And when you're reaching out to an audiologist and referring or asking your family to refer, you're going to want to ask the audiology office if they do 2 things. Number 1, this is a great time to take notes. Write this down. You may want to write this down. Number 1, do they test auditory acuity the same day in the same appointment, they test auditory processing disorder? That answer should be yes, because the bones in our ears move from day to day and it could skew the outcome. So you want to make sure the audiologist tests auditory acuity on the same day they test auditory processing disorder. Also, do they do the testing in a soundproof booth? There is no standardization for testing for auditory processing disorder, but best practice is a soundproof booth. So you'd like that to be yes. So it's important to have auditory acuity tested as well as auditory processing. So very good, Chris. That was absolutely spot on. So Eva, you talked about he could quickly write the short one-syllable words. Well, that's interesting. He phonetically, I think, sounded them out. So we had him, I said the word with, he said with, and he sounded it out, but he used L's for T's. I wonder why that is. Any ideas on why that is? I'm going to leave that question open while I move to the next. They are doing a good job taking their time to try and figure out how to spell, but it's likely they need more time than their classmates. So that's really interesting. I think, and we'll get to this a little bit more with strategies, because giving time is the number one strategy we give with people with dyslexia. However, we need to tie that to evidence-based of why we give time. And there's a way to know if giving time will be successful or not. But the other thing I'm picking up from that comment is this child's had significant reading intervention. And the way you know that is because he has done an excellent job sounding out the letters, the sounds associated with the letters he's hearing. He's not always getting the correct sound. And even when he sounds it out, he's not writing the correct letter. So what that tells me is he's had significant reading intervention. So next step moving forward, I would not do reading intervention again, because he's had a significant amount of it. It's not working. There's something else going on, and we need to find out what that is first. So definitely putting in a lot of effort. He's also putting in more effort than he should be. So he's probably hitting fatigue as well. So that's something else to think about. Segmented letters, forming letters from the bottom up. Yes. Great observation, Joe. That makes me wonder about vertical midline. It makes me wonder about maybe visual perceptual skills or eye teaming. What I'm not worried about is handwriting instruction. He's had a significant amount of handwriting instruction. How do I know that? He's writing from bottom up to keep his letters on the line. Someone has taught him the importance of keeping your letters on the line. It's also very legible, which is rare for a kiddo of his age that has this learning concern. So I would be looking more at the visual perceptual skills and visual memory than handwriting. I would start there. Let's see. Fine motor, index grasp with thumb, IP hyperextension. Absolutely. Visual motor, starts letters from the bottom, has to think about how to form the letters. Yes. So he has to think about how he's forming the letters. Vanessa, that makes me wonder what his visual memory is. How is that working for him? Do we need to test that visual memory? And why is he holding the pencil like that? Well, could it be weak intrinsic muscles? Can it be weak core strength? We develop from proximal core, meaning our trunks to our pinky. And so he's really struggling holding that pencil. I intentionally put a short pencil in front of him to see if he could do a tripod grasp or not. And he's struggling to do that. So I would go back and test his primitive survival reflexes. I would test his core, because what if he doesn't have any learning disabilities? What if he just has a weak core? Because if we're just trying to hold ourselves upright and taking all we can to just stay upright, think about how our balance is then thrown off when we reach our arm out in front of us, because now there's distance and now our stability is moving. Now we're having to process, what did we hear? What letter is that? How do I write that? How do I hold this pencil? There's so much going on that it's just falling apart. So if we addressed his core strength and his low tone, he may be just fine. I'm not saying that's the case and that's always the case, but if we're working with a child that's demonstrating this posturing and difficulty with grasp, we absolutely would not be serving the child well if we didn't address core, grip, pinch strength, tone. So very good, Vanessa. Yeah, he strangled the pencil. It took everything he had to hold on to it. And again, Joe, I think that might have to do with tone and or muscle strength, core and distal. Very good. Roxanne writes firmly, needs sensory feedback, needs time to process, uses phonological skills. Yes, uses phonological skills. Again, back to excellent prior reading instruction. He's had a significant amount of it. I'm curious why he's writing firmly and if it's a sensory feedback or if it's stress and fatigue. Is it anxiety because he is struggling to try to put the pieces together? So we're not sure. But yes, Roxanne, you're on a good path, meaning this is the list. When we're making observations, we don't have to be correct. We just have to make the observations and make the list and then start doing additional testing to rule it out or say, yep, that's it. So don't be afraid of the right or wrong in terms of observation. Just keep peeling that onion layer back to find out the why. Never ask for word confirmation. Exactly. He never asked because in his mind, he was figuring it out. So he was incorporating all of his strategies to make that work for him. Sarah, welcome, Sarah. While CAPD might be rare or seriously underreported, we do work with auditory processing problems very frequently. People with seasonal allergies have challenges hearing, speaking, spelling, recognizing words due to nasal congestion and fluid in the ears. Yes, thank you for bringing this up. This is a great point. And deficits in delays in attention focus and in their allergy medication is or is not affecting their systems. ADHD or SPD or ASD or anxiety can impact students' ability to process auditory information efficiently. Great point, Sarah, and I appreciate you bringing that up. So again, it's peeling that onion layer back and asking the questions of why, what are the possibilities, make that list and start exploring. So well said, Sarah. Thank you for that. But the processing time here is a good category to hone in on for treatment and to find out why. Yes, 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 yes. I'd like to see him do a simple puzzle. Yes, because again, we're looking at spatial relationship skills, right? How does he know how to connect the little line with the little curve? Where is this coming from? So great point. I appreciate that. So thank you for sharing your observations. And I hope that this was valuable to you. Now let's take another peek at this from a different vantage point. This is this young man's work. And let's say that you were the parent. Or let's say you were the classroom teacher in a room of 30 kids and you did not have the opportunity to sit one-on-one with this child and oversee everything that was going on. So you open the backpack, you get the list of papers on your desk, whatever, and you just pull this up. You have no context to put this in, and this is what you see. The red C's that you see to the left, this is indication of correct. That's what the C means. So remember the eidetic words, the words that he was able to read, that's what he wrote on the left. The phonetic words, the words that he was unable to read, but we wanted to know phonetically, could he sound them out? That's what he wrote on the right. Do you have additional or different observations or more context to add to the story when you see it like this? And if so, place it in the chat. Meanwhile, I'm going to go ahead and answer Joe's question. Why has he had so much reading instruction and just turned 7? All this intervention when he was not developmentally ready may be a big part of the problem. Interesting. That is interesting. So, yeah, that's interesting. Not sure I 100% agree. Okay, I do agree he's not developmentally ready. I am on board with that. However, in kindergarten, we're expecting children to be able to write their name and read on a certain level in kindergarten. So he's at the end of first grade. So he's absolutely reading. So probably somewhere around the end of kindergarten, his parents may have taken him to an after school program to help support his reading. Then maybe in first grade, he started getting on an IEP for reading. So because by third grade, that's when you're reading to learn and not learning to read. So if he's at the end of second grade and not getting some instruction by this time, there's no way he's going to be caught up. So like, yes and no, developmentally, you're right, Joe, he wasn't ready, but because the schools have such a high criteria and high bar for reading expectations at such a young age, they couldn't help but not do it. So it's kind of a catch-22, but it is still a valid observation, Joe. I appreciate that. Decreased visual memory. Yes. So maybe assess memory. Excellent. I wouldn't expect him to spell more words correctly than he couldn't read. Ah, okay. So Roxanne, I had to think about that for a minute. We're not looking on the phonetic list for him to actually spell it right. We're looking to see if he can spell it the way it sounds. So for example, on number 4, the word was store. Even though the E's not on there, he got it right because phonetically it's correct. Number 1, the word was read. He didn't spell it correct, but he got it right because phonetically, vowel, consonant, vowel makes this E a long E. So it phonetically sounds as read. So that's why he got it right. We're not looking, I'm sorry. That's not right. Cool. That's what I meant to say. So cool is spelt with a C, right? Let's see. So we're really looking for just phonetic spelling here. It looks like the words he could read have more errors in letter form and direction. There's a few things I thought was interesting too. If you take a look, let me use the laser pointer here. If you take a look, you can see a few letters where they're really darkened, where he perseverated a little bit on writing the letter. And I don't know if he was buying time and just pausing because maybe he needed rest, or maybe he's questioning himself. You know, I know it's a tall letter. I'm not sure if this is the letter, but I'm putting it here anyway, or if he's checking how he spelt it. You know, we're looking at, I think it was Joe that mentioned, you know, vertical midline right here, how he made that U. The other thing I thought was interesting was on the left-hand column, he really spaces the letters far apart. And on the right-hand column, they're spaced more appropriately. Did he think he had the whole row? Not sure what's going on here, but I thought that was interesting. I can see he's had significant handwriting instruction because it's very legible. Everything's on the line almost perfectly and things of that nature. It looks like, it looks like words he could read have more errors in the letter form. Yes, that's right. Okay. Good job. So I hope this was helpful in going through this exercise together. Okay. All right. So this next item we're going to see here, this is a different child. I'm asking him to do the VMI. And if you aren't familiar with the VMI, he basically sees a shape and he has to copy it. And what I'd like you to look at in this particular assessment, and it starts at the very beginning of the video, how he is holding that pencil and how he compensates with writing. And also look at the strategy he uses, and we'll talk about it. Write your observations in the Q&A as we're going through this, if you wouldn't mind, and we'll discuss those comments. Here we go. Okay. And just for reference, that banging you hear is on the other side of the wall. Someone is banging. It's not him kicking the desk, but go ahead and put your observations in the chat if you wouldn't mind. What did you see? What are some things that gave you pause, gave you concern? What would you address if you were their therapist? And why is this important? Let's talk about while all of you are putting things in the chat, let's talk about why this is important. Think about students that are copying notes from the board. Think about handwriting skills. So this is why this visual motor integration skill would be really important, that hand-eye coordination. So why do you think he switched pencil grasps at the very beginning? What are your thoughts on that? Why did he switch pencil grasps? So Sarah saw some strengths here that he was shadowing for muscle memory to copy line by line. So I wonder, yes, is it muscle memory? Is it visual memory? Again, we don't know, but yes, let's get these tested. He leans very close to the paper before copying the shape. Yes. So are we concerned about visual acuity? That's something we might want to check. He changed to a more stable, still immature, but more effective grasp. Yes. So Sarah, you answered my question. That is why he changed his pencil grasp, is because it needed to be more stable, because you could see at the beginning how shaky that was. His line right here was just very wobbly, but once he changed, you can see how straight the lines become. So it did provide him that stability. Okay. So we have a couple of people who commented on pencil grasp. From a treatment standpoint or further assessment standpoint, what do you do with that information? What would you do next? What would you want to look at next? What's your concern about the stability with this pencil? A few people mentioned that. What would you do? Roxanne, you're right. He is working hard, super hard, too hard. So we really need to think about his psychosocial needs, his self-esteem, self-concept. We need to take a dive into that as well to provide him with support. Okay. So because he had to do stability with that grasp, what would you do? What would be the next thing? Directionality, confusion, spatial relationships. Yes, Christina. We may want to do further testing for that. Use a kinesthetic strategy first to measure the length of the lines, a good strategy. Yeah, so that's interesting, Vanessa. Pros and cons about this. It's a good strategy for what he's doing. For an ongoing, sustainable strategy, is this going to work for him in the long term? Is the strategy of going up, tracing over it, and then going back to where he needs to copy, is this an effective strategy that'll be successful for him as he goes on in his academic experience? Yes, no. Vanessa talks about possibly visual acuity or processing or reflex issues. Yeah, so you'd want to get all that tested. Is the tracing a good long-term strategy? I'd love to hear your thoughts on that. I'm just reading the Q&As we're going. Anything new, I'm going to share. In the school, we would support and adapt. At the clinic, we would work on neuro rehab strength. Nailed it, Sarah. That's exactly right. So why? Why don't we do both in school? Because if we're just working on supporting and adapting, it's a Band-Aid. We're not actually addressing the source, the real issue, the root cause. So we definitely still want to work on core strength and all that, those other things, reflexes, and find out what's going on to fully support the child. How is core strength? That's right, Roxanne. Definitely want to take a look at that. Look at hand strength. Yes. He had the strategy, but not able to keep up. Yes, for copying shapes, not for visual processing. Not if you had to copy something from the board. Joe, that's exactly right. and that's where I was going with this. So we need to be really thoughtful when we're thinking about strategies that we allow to continue or that we foster. And we need to set parameters around that and make it clear what it is to be used for. Because if this is a strategy that we allowed to go on without addressing it, we're like, oh, he's got this strategy, it's working, no need to address it. He will struggle when he goes up in higher grades and has to take notes from the board. So no, this is not a good strategy for him. And I agree with all of you. We need to look at, visual perceptual, visual memory, core, primitive reflexes, maybe even sensory. So you guys are right on strength, shoulder stability, grip and pinch, all of that we need to look at. So excellent, excellent, excellent. You guys are on top of it. I'm just going through the rest of these. Lots of good replies here I'm reading. Tracing will not help copying from the board or group work in the classroom. That's right. Change positioning at the table with this seating or slant board, built up pencil. Yeah, there are some options there. Absolutely. When we had my daughter assessed, we were required to bring an eye or ear exam that was less than 1 year old. Is that not standard for assessment? Not all the time. It depends on who is doing the assessment. I know when I worked with children and did assessments, it wasn't required. I would do assessments, and if I thought it was a concern, I would suggest that parents then go get testing, but no, it wasn't required. It was encouraged, but not required. So I think it just depends on who's doing the testing. It's always helpful if it can be done though. Okay. You guys are doing great. All right. So we talked about the 6 steps of working with individuals with dyslexia. And the first one is meeting them where they are. Remember, that's that psychosocial piece, connecting with them, making that relationship, building that trust, observe and gather. And that's what we just did. We practiced our observation skills. It's not, I'm sure many of you already know this, but it's always worth saying, just as a reminder, the percentile rank or the score is not always the richest and most valuable information we get from assessment. The observations we make are so important. Context matters. And you may want to expand on this, observe the child in other environments. If you're at a school, could you observe them in the cafeteria? And I know many of you observe them in the classroom, on the playground. Talk with other people that are, that work with this child, or, have encounters with this child. Maybe the person who works in the cafeteria, maybe the person who monitors recess or pickup after school, or the bus line. Watching a child in multiple environments and getting feedback from multiple people will give you such a well-rounded picture, because the environments and stimuli are different. The expectations are different. The child will be more independent, or be required to be more independent in some settings than others. And so you'll get a nice, well-rounded understanding and background of what's going on with the child to help you move forward with your next step. So you heard me say this before, dyslexia is not about reading. I used to be very scared to say that. And now I'm so firm on that, just from all the research I've read, the research I've done, and my clinical and anecdotal experience. I think it's worth kind of pausing here for a moment, because I find it interesting that when we are presented with a child with dyslexia, when I say we, I mean the provider, whether you are a dyslexia specialist, a reading teacher, whether you are an occupational therapist or anything of that nature, we automatically go to reading. And I think the reason we do that is because reading is very measurable. It's very black and white. We can touch it, we can feel it, we can see it. It's absolute. And when we take a look at all the reading programs that are out there for dyslexia, they were all created by people from the education field. And if you take a look at the research behind their programs, you can see that executive cognitive function was addressed. yet it's not included in their programs. And my humble opinion of the reason it's not included in their programs is because they are doing what they are experts at doing, and that is reading. And so our educators do not have the background or experience of building neural pathways. They didn't take neuroanatomy in school. They didn't take courses on physical disabilities and learn about cognition and how to treat cognitive impairment. And so, that's on the back shelf. And so that's my humble opinion of why executive cognitive function doesn't get directly addressed head on. However, the magnocellular theory of dyslexia has been around for a very long time, and it talks about the impact of impaired executive cognitive functions and what it has on dyslexia and reading intervention. And so what I'm positing to you is the marriage of that, right? The medical model with the educational model, or implementing the magnocellular theory of dyslexia to support your evidence-based practice and best practices when working with a child with dyslexia. Before we started today's webinar, Joe, who is our host for today's event, was sharing with me how excited the team at his in his school district were about today's event, because we really just don't have the tools or aren't addressing dyslexia. And my response to that was, I bet you are, and you may not realize you are, but because you're OTs and because you understand looking at the whole person and addressing executive cognitive function, you're probably doing a lot of these things, but not realizing that it connects to dyslexia. And I think that might be the opportunity to kind of have that aha moment of, oh, I really am. So let's kind of take that dive on what that looks like. So reading is a very high level skill that requires building blocks to get there. So we have to have emotional regulation. We have to have executive cognitive function that's average or above. We have to have good overall mental wellness in terms of self-concept, self-esteem, self-worth, our confidence that we can do something. Then we're learning early emerging reading skills, and then we're remembering them, and now we're applying them to reading. So they all tie into each other. I want us to take a minute and just kind of think through this and how our skill of observation can be honed in to really get a child off to the right start. How do we know when we need to refer a child to therapy versus reading intervention? And when do we do that? So let's say we have two students that are presenting the same. And when I say presenting the same, I am inferring to the fact that they may have below average performance on academics, but we don't know why. They're both performing low on reading. So traditionally, since they're both performing low on reading, what we would do is send them for reading assessments, reading support, and they would both go down the reading path. So the child on the left, let's call him Johnny, he's going to excel and do well. But Tom on the right will not. And let's take a deeper dive into why. So Johnny on the left, his neurodevelopment is fine. And when I say his neurodevelopment is fine, I want you to go back to the slides that we showed you with Dr. Sally Shaywitz, how a letter form recognition, Warnicke's area, and Broca-motor were all appropriately developed and working just fine. He's just not accessing them. Why is he not accessing them? Could be a variety of reasons. Maybe he's from a military family and he's moved around a lot and he's missed curriculum. Maybe he's from a low socioeconomic and there's not opportunity. Maybe parents are working 3 jobs. Maybe there are no books at home. Maybe parents are illiterate or have difficulty reading themselves and he just doesn't have that support. So, or maybe Johnny has used a lot of compensatory strategies and he's fallen under the radar. But if he just has that extra support, he'll do fine. And how do we know that it's because he's not tapping into it? Because he's doing below average in everything. There's nothing that he's excelling at. There's not that difference of this is where reading is and this is where everything else is. So there's not a gap. And you know that from observation, looking at his grades, looking at what he does, looking at, everything that's going on from your observations. Then let's take a look over here and look at Tommy, and his neurodevelopment is immature. Did we do a functional MRI to determine that? Absolutely not. How do we know that? Because he's the one that has those symptoms that make no sense and don't connect. He is the one that has that difference between, spelling is just brutal, or he reads great, but can't remember everything he reads, or he reads very robotically, or he avoids reading, or he doesn't like to be called on in class, but really good at math, loves science, very active in sports, easily makes friends, or anything of that nature. But there's this big difference. And the parent will usually tell you a list of all the concerns, and they'll all wrap up with this statement: but he's really smart. You will hear that 100% of the time. Not that he's gifted, not that he can do it. You'll hear the word smart. It's really interesting. And this is anecdotal and from my clinical experience, but I hear it 100% of the time. Listen to those parents' stories. Or when a parent tells you things and it's not making sense and you're saying, I'm not sure that's what I see, believe the parent. Why? Because oftentimes children with dyslexia, they'll present one of two ways in school. Either they'll be the class clown or the troublemaker, because what you're asking them to do is so hard that the consequence of misbehaving or acting out is easier for them to handle than what they're being asked to do. So that's one option that you'll see. The other way a child will present is this will be your people pleaser. Socially, they get along with everybody. You love this student. You want every student to be this student. You adore them. They're cooperative. They're pleasant. They're easy to work with. They are doing everything they can to cover it up, and they are doing everything they can to hold it together. And when they get home and they get picked up, they're falling asleep as soon as they get in the car. They're melting down at home. There's temper tantrums at home. Their home is turmoil. So when parents tell you this, and it's a stark contrast of what you see, don't discount the parent. It's because the parent is the safe place to land that the child feels that they can just have that decompression and unwind. So really use those observation skills to take in, what is the parent telling you? What are you seeing in performance? Ask your team. These are all different things that'll lead you down to the conclusion that the young man on the right needs referral for OT and speech. At the same time, they're getting reading testing, not after reading testing. It's not an afterthought. It's at the same time, because if they're scoring low on reading, your OT may be able to say, oh, but they've got visual perceptual issues. And your speech therapist might say, they've got some processing issues, which will help you develop a good plan. Versus the gentleman on your left, where he responds really well to remediation. So I would not send the gentleman to the right to response to intervention, because what you're really waiting for there is you're waiting for them to fail, because that's what will absolutely happen every time. So that's where your observation skills really come into play. Before you do any formal testing, you can get your kiddo off to a good start. So there is a question. Thanks for saying this. As a parent, I have one of the pleasers. Yes. Teacher last year was shocked that she had an IEP. Yeah. So I think thank you so much for mentioning that. I'm so glad there are parents here. And that's why I encouraged parents to be here, because they will see the other side of it. They are a very important part of the team. And all of us need to come together and not be shocked, right? My daughter's third grade teacher during parent teacher night said this to us. It was great. I'll make a deal with you. If you don't believe everything your child says about what goes on in this classroom, I won't believe everything that goes on in school. And at first I'm like, you're on, right? But really, we shouldn't be shocked when the parent and her teacher gives us a different story, because we have different expectations. They're in a different environment. The child will present differently, especially if they're struggling. Okay. So again, we're going over the 6 steps, meet them where they are. That's that psychosocial component. Give them that support, observation and gathering, and then finding the right path. So when we compare these 2 young boys, that's what we were doing. We were trying to find the right path as early on as we can. So here's the big question. Okay, Dr. Stack, we know we want to refer them to speech and to OT and to psychosocial testing, but the caseload is so large, it's going to be months before they get in. Okay, I get that. That's real. And so that's when you're going to do some observations in the classroom. Let's say, for example, you see they're having difficulty with handwriting, just like the one therapist said earlier, have them do puzzles. Have them do activities that lend themselves to the skills to do that task. If you're noticing they're asking you to repeat instructions a lot, maybe look at memory activities you can do with them, or try to figure out if it's processing issues. So really think about what is the struggle, why, and if you don't know, then reach out to the therapy team that you have and say, hey, I'm noticing this on a kiddo in my classroom. I think we're going to make a referral. I know it'll be months before you get to them. Any ideas on what I can look for or activities, in free time I can give them that'll support that? So those are some things that you can think about doing. Okay. So I made this slide because, as you know, when my daughter was diagnosed, I was running into kind of a wall on providing her services. So I started reaching out to my colleagues, OTs in speech, and I said, hey, what do you do with children who have dyslexia? And many of them shared with me exactly what Joe mentioned earlier, and that is, I don't know. I don't. Well, who do you refer to? We don't really have anybody to refer to. And I thought, okay, but it's a cognitive issue. And they're like, no, it's a reading issue. So then I started asking them different questions. I said, do you do evidence-based practice? Yep. Do you know how to build neural pathways? Yes. Do you know how to do multisensory intervention? Yep. Do you address deficits that are found when you do an evaluation? Yes. Do you know how to address visual, motor, and visual perceptual skills? Yes. Do you address visual memory and auditory memory? Yes. Do you work with sensory integration? Yes. Can you address primitive reflexes? Yes. Do you address psychosocial issues? Yes. Guess what? You can work with individuals with dyslexia. So if you are an occupational therapist, this is your seat at the table. If you are not an occupational therapist and you see your client having these difficulties, this is a great opportunity to refer to occupational therapy, whether it's in your school system or in an outpatient clinic. These definitely need to be addressed and can easily be addressed by an occupational therapist. So this is that moment. I really would like occupational therapists who work in the school district to just reflect for a moment and say, oh, I have been addressing dyslexia and I can address dyslexia. So I hope this boosts your confidence a little bit to realizing that you may not even realize that you have been addressing some needs of dyslexia without even knowing it, just because you did the assessments anyway and found the deficits and are working on them. So good. And I am keeping an eye on our time because I know we're getting close to break. And remember, this is going to be uploaded on YouTube. So if there's anything that you miss, you can always watch what you miss. So we've talked about executive cognitive functions. Let's talk about the functionality of it all. And that is, the student or a child come to us with difficulty in reading. And traditionally, we assess their reading and we send them to a reading specialist, a teacher, a dyslexia specialist, or a person of that nature. They start with phonological awareness, associating sound with letter, different letter combinations, making different sound phonic rules, phonological memory. And when they do that, they go back to see if they have difficulty reading. They still have difficulty reading. They come back to phonological awareness, phonological memory, and they just stay in this closed loop system. And that's where the intervention starts and stops. Versus trying to move this bar out of the way so it's not, whoa, that is not what I meant to do. Sorry. Okay. Versus referring out to speech therapy and or occupational therapy to assess auditory memory, visual memory, maybe to psychology to look at IQ. There is some older research out there that says if you have IQ average or above and your reading is below average, and that's an indication of dyslexia because your reading ability is not up to your potential of what you can do based on your IQ. There's more recent research that says IQ really has no impact on dyslexia. I am on the middle road of that. I used to only work with children who had an IQ average or below, but I had this one client come to me and her IQ was below average, but there was something about her that just spoke to my heart and I could not say no. By the time we were done with services, she was reading at an average or above average level, even though her IQ is below average. And that convinced me to throw IQ out the window and work with children to address their deficits, no matter what they were, how they presented. Addressing visual perceptual skills, visual motor, fine motor coordination, and also looking at lack of opportunity and lived experience. These were all important components when we're working with individuals that have dyslexia. All right. So for today's webinar, we don't have the time or the luxury of taking a deep dive into primitive reflexes, but I will tell you, I am a data junkie. And so anecdotally, I started keeping a spreadsheet with the primitive reflexes like spinal gallant, tonic, labyrinth, ATNR, STNR. I listed them. And if a child had a deficit, I coded them by numbers. So there was no name, but I would list what reflex they were positive. And then I also tracked the test for information processing skills, which looked at memory, visual and auditory, short-term, immediate, short-term, long-term, delayed recall. And I also tracked the CTOP, the comprehensive test of phonological processing skills, because I wanted to see if there was a correlation. And I did find a correlation. I encourage you that if you want to dive into primitive survival reflexes, that you take a course that is specific for this. But these are the reflexes that I typically would assess. And I'm going to give you a resource that you can use right before we go to break. So I want to show you something. Okay. I want you to write this down. Lisa Foss, L-I-S-A, Lisa Foss, F-A-S-S. And you can type in Lisa Foss, primitive reflexes, if you want to. She's got this great website, and I don't know who she is. I just love her website. And what I like about it is it's a great resource for parents or for therapists who don't have expertise in primitive reflexes. It'll list the reflex, why it helps children, and what are some issues if it's not integrated. And so when you go down the spinal gallant reflex, you can see if it's not integrated, they may have difficulty with fidgeting, which people may interpret as ADHD. They have difficulty with memory. So I've noticed a strong correlation between children who are positive for spinal gallant reflexes also scoring really low on their memory testing. And so if they scored positive, I would have them work on activities to integrate that reflex. Usually you could do it anywhere in 4 to 8 weeks. And so if that deficit was due to not integrating the reflex and we just reintegrated it, then that deficit went away. If it was that and dyslexia, the deficit presented a much more minimal interference. And if it wasn't due to the reflex, it didn't change. So etiology was hard to determine, right? But it doesn't hurt to treat the reflex at all. And the other thing I like about her site is if you go to this bottom button right here, it says yoga poses for primitive reflex integration. And it will give you a video on how to do that activity with the child. So I would show this to the parent during conference. I would have them do it with their child, or the kids they have at home. So it's just a great resource. And I just wanted to pause a minute and show you that. And again, that is Lisa Foss, and Brain Gym, a lot of activities that can work on this, not just this. The other thing is, I was never sure if this was truly a neurological issue or lack of opportunity. I noticed from my experience living in Oklahoma, when I had children that came to me from Oklahoma City or Tulsa, which were the two big cities in Oklahoma, they had a higher incident rate of sensory issues and lack of integration of reflexes versus the children that came from the farms, the cattle ranches. They seem to have less of a prevalence rate. And my anecdotal conclusion to that is because they were out playing more and more active, whereas children that were living in the cities were not as active. So that was just some anecdotal, very interesting information. So at that point, let's go ahead and pause for. Welcome back. I hope you were able to take a break and stretch a little bit. We have a great question, and it says, are there reading programs, for example, LIPPS, that work for kiddos with dyslexia? So I always get asked a question about reading programs and dyslexia reading programs, and I just want to bring us back to the fact that I am not a reading specialist. I am not a dyslexia specialist in that sense, like a certified language specialist or anything like that. I am an occupational therapist, and I bring this information to you through the lens of an occupational therapist. With that said, I believe there are many programs out there that are successful. I do not believe that there is one program specific for dyslexia that will fit everybody. But the one thing I do know for sure is if you address the executive cognitive functions and you take the skills, what you're learning today, and implement them, it will positively impact the outcomes of the children and students that you work with, regardless of the reading program or protocol that you use. And I think that's the important piece, is to support those programs by addressing those executive cognitive functions. So great question. I appreciate the ask. All right, so let's move on. And we are now going to specifically address visual perceptual skills. So as occupational therapists, you're probably very familiar with these, but there may be people that are viewing this that aren't as familiar with visual perceptual skills. So I want to go over them. And instead of giving you a definition of what each of these skills are, I'm giving you an example of how it will present. So when we think of visual discrimination, this is where you can find things that look alike in a variety of things that are different. So think about when you're at home and you pull open your drawer where you have all of your flatware. And if you're anything like me, you probably have different flatware patterns just because of living over the years. Can you choose two forks of the same pattern? That would be a visual discrimination activity. For your ground, where's Waldo? So think about going into a closet and you want to wear your polka dot shirt. Can you easily grab that polka dot shirt when it's among a paisley shirt, a striped shirt, a solid shirt? Where's that polka dot shirt? Easily grab it. Or this happens in my home on a daily occurrence. I'll ask my husband, because I love to cook, I'll ask him to grab something out of the pantry or out of the refrigerator. And it's right in front of him and he'll tell me it's not there. That's that figure ground skill. Can you find something among all the clutter? So think about the child who is in a very busy classroom. There's lots of decoration on the walls. There's just a lot of visual stimulation going on, and you're asking him to go over to the bookshelf and grab the colored pencils. Well, there's also markers there and crayons there and blocks and all these other colored items. And he may be looking right at them and telling you he cannot find them. That's a figure ground skill. Or you're trying to find a word in a textbook and you're trying to find it in a paragraph and you can't pull out the word. Those are figure ground deficits. Visual memory. You see it, now you don't. Do you remember what you see? Think about when you're copying notes from the board and the teacher's writing a sentence. Do you have to look up every time to find out the next letter of the word? Or are you able to remember the whole word and then look up the next word? Or can you remember the whole sentence and write the whole sentence? Do you remember how to form the letter and what that letter looks like when you're writing? Spatial awareness. This is putting puzzle pieces together. This is also being able to connect a little line with a little curve so you know how to form the letter. Visual closure. What will the shape be, even though it's not completely drawn? So you have 3 sides of a square. Can you anticipate that's going to be a square versus a triangle? Form constancy. So think of this. Grab a piece of paper and write for me a lowercase b as in Bravo, P as in Paul, and D as in Delta. B as in Bravo, P as in Paul, D as in Delta. Lowercase letters. So now that you have all those lowercase letters written, are they the same form? In the Q&A, yes or no? Are those 3 letters the same form? Want to see your opinion in the Q&A, yes or no? Lowercase p, lowercase b, lowercase d. Roxanne says yes. Anyone else with a different view? Are they the same form? Vanessa says yes. Yeah, they're the same form. Hannah, you're right. They are the same form. However, visual discrimination tells you they are different letters. One is a P, one is a B, one is a D. Spatial awareness is a skill that tells you where to put that little curve against that little line to make the letter you're wanting. For your ground is the skill that you use to know which one is the P, which one is the D. You know, where is it among all the letters? Visual memory helps you remember what that letter should look like when you need to write it or read it. So you can see that each of these visual perceptual skills have a very important role in reading and writing. So we'll talk about testing a little later on, but while we're here, I'd like to mention the reason I chose to use the test for visual perceptual skills is because it tests all of these skills and then individually will give me scores for each of these categories. So overall, their visual perceptual skills may be in the 30th percentile rank, which is average. And if you did the MVPT, the motor free visual perceptual test, you might say, they're good to go, no worries here. But if you did the TVPS and they have overall of 30, but figure ground, they're in the 90th percentile rank, and form constancy, they're in the 2nd. Even though they're average overall, I'm going to work on form constancy because that is an important skill. So think about why you're testing, what you're getting out of it when you're choosing those tests. All right. We have a question by Christina. Is visual discrimination both discerning like items, then also finding the differences? Yes. I had someone able to match, but not find the differences in the figures. Yes, I would think visual discrimination would do both of those. So that would be something that maybe you could work on or get support for that child. That's a good observation. All right, we saw this slide at the beginning. And now I'd love to hear your answers, but for sake of time, I'll just give you the answers. But look at your notes and see what answers you had in comparison to the answers that I'm sharing with you. Dyslexia can be cured. No, but it is treatable. And some people struggle with seeing the difference. So cured means it goes away. You never have any of the problems again. You're cured. Treatable is you can increase ability, but they'll always have it. So for example, when we as occupational therapists work with individuals with dyslexia, we can increase their processing speed, we can increase their capacity to remember something, and we can increase their visual perceptual skills so they are interpreting what they are seeing correctly, which will increase their reading rate, help them keep up with their classwork easier, We can also teach them some strategies so they have less of a struggle. This will increase their self-confidence. And so they can function and keep up with the work that's expected for them at their grade level. But let's say they're not feeling well, they've got a lot of stress or something of that nature, all those characteristics and symptoms will come back. And then once they start feeling better, they can go back to, it'll just automatically, all their strengths will kick in again. Dyslexia is not curable, but you can treat it to the point where somebody can be functioning at a much higher level. So that would be the difference. Dyslexia can be outgrown. No. Children with dyslexia grow up to be adults with dyslexia. And this is important. When I tell people I work with dyslexia, they automatically associate me with a pediatric therapist. And I tell them I am not a pediatric therapist. And they always have this puzzled look on their face. And in my mind, when I think of a pediatric therapist, I think of somebody who works with a variety of diagnosis, whether that's PANDAS, somebody that may have cerebral palsy, maybe a child that has sensory integration issues, reflex issues, maybe swallow and suck issues if it's infant feeding issues. I think of all these wide variety of needs a child might have to address. You do not want those children seeing me. Not my area of expertise. I would have no idea how to support them. I work with individuals with dyslexia. So my youngest client was 4.5 and my oldest was 65. Why? Because adults also have dyslexia. So a lot of questions I get when we talk about the treatment portion later on this afternoon is, what age would you use this for? What age would you use that for? I do not take age into consideration unless it's an age appropriate activity. I take into consideration their test scores and what they're able to do. So I measure it against their scores, not their grade or age. So just kind of keep that in mind. Dyslexia is a neurobiological condition. It's a language disorder versus a visual disorder. That's right. So remember Dr. Sally Saywich's research, excuse me, when she talked about the underdevelopment of letter form recognition and Wernicke's area. You do not get dyslexia because you have a visual perceptual disorder. If the dyslexia font cured your dyslexia, and if the corrective lenses you got from having Irlen syndrome corrected your dyslexia, or the medication you took for your ADHD corrected and cured your dyslexia, you did not have dyslexia. You had visual perceptual issues, eye teaming issues, ADHD, or Irlen syndrome. However, if addressing these things made your life a little easier with dyslexia, you had both. So the dyslexia fonts and all of those things associated with supporting dyslexia are really supporting the visual perceptual issues and oculomotor issues that you're having that are not due to dyslexia, but interfere with dyslexia. So just understand that and understand the difference. The lived experience is important in the assessment and treatment with dyslexia. Absolutely. Really hearing the parent and the client's story is important, and it becomes more important as your client becomes older. So if you have a person who is a senior in high school or has significant college or has graduated from a significant amount of college and you test them for dyslexia, they may do really well and on tests not indicate any signs, any indications from standardized testing that they have dyslexia, because they can do really well. However, that lived experience, that disconnect that we spoke about, that is often how adults are diagnosed with dyslexia. And there are different types. There is developmental dyslexia, which is something you are born with. It's genetic. And there is acquired dyslexia, which you can acquire through trauma. So I'm curious if your answers were the same. But anyway, it's just something to reflect on. All right. So let's talk about evaluation. I'm really convinced that there are three main components that have to go into working with somebody with dyslexia in order for you to have success. And the first thing we need to consider is the team. And I'd love some participation here because it just makes it more fun. But I'm going to ask you to put in the Q&A, who is the most important person on the team? And I'll take a moment for you to write that in there. What role, who is the most important person on your team? Absolutely, the client. It's not the parent. It's not the professional. It is the client. And all of you are answering that. So I say that because the interesting thing, kiddo, I love that. Yeah, it's the kiddo. The interesting thing is they are the most important person on the team, but they are the one that we address last. And what I mean by that is the parent or the teacher or somebody refers them to us and we see them. And we do testing. We meet as a team. The child's not part of the meeting. We decide they need services. The child's not part of that decision. The first time the child might hear anything about it is after the parent gets done with the IEP. The parent sits down and talks with the child, but often the parent doesn't know how to, or the parent does not. Or when the child's being pulled out of class to go do something, they have no idea why they're being pulled out of class to go do it, which sounds kind of backwards if they're the most important part of the team. So I really encourage us to consider bringing them in on the decision-making process to the level of their ability that they can understand it at the most appropriate time before we start pulling them in for services, so they understand and they can have some say and feel that they have power over their own destiny, have some choices. So it's really important to include the child in that process. The other thing that's really important is we need to have neural pathways built. This is where your therapy team can come into play. So when we decide to have a child tested by psychology or the school psychologist or a clinical psychologist, a neuropsychologist, at the same time, there should be a referral for OT and speech. When we talk about building neural pathways, let's say they don't qualify for OT. We want them to work on auditory memory because they scored really low. Could we visit with the music teacher and maybe see what we can come up with some activities in there, or the classroom teacher that would help support their memory? Or maybe it's visual memory. Can we talk to the math teacher or maybe the art teacher? So the variety of things that you can do that's a little outside of the box that can help support the child. The child will also need some tutoring. So when I think of tutoring, I think of extra support for what they learned in school that day. Do they need somebody to go over the instructions with them again? Do they need extra practice? Do they need it broken down? This is not remediation. This is just tutoring. Why? Because they may have been pulled out of class. And that's my other soapbox. I may as well say it now. If I had my wish and children were being pulled out for support services, the first classes I would choose to pull them out of are math, science, reading, language arts, which cause a lot of people to gasp, except the people that live with dyslexia. Why? Because they are sitting in those classes struggling, and it's chipping away at their self-concept and self-worth. You need to keep them in music, recess, art, not pull them from those classes, because they need to feel successful, and they will also be building their executive cognitive functions in those classes. And they'll be learning all those other things in a way that's easier for them to understand. So that's just my bias. Thought I'd share. And then the other thing they'll need are instructions of how to use strategies and accommodations. So I provided you with a handout. Oops, hang on. I'm going to see if I can open that. I provided you with a handout that you should have received, and they are some suggestions for the school, and they're basically just accommodations and strategies. And we're not going to go over each one of these things individually, but I have them here to make a point. When a child is tested by a clinical psychologist, school psychologist, neuropsychologist for educational testing or for dyslexia, they typically at the end of their report will have a list of strategies or accommodations for school. The list is just that, it's a list. And it can be overwhelming for the user end to know how or when to implement those accommodations or strategies. So you can see that what I gave you is just a generic list. I usually customize these for clients, but I gave you this one because it's broken down so it's user friendly, modifying the presentation of the teaching materials. If you want to, maybe their memory, their auditory memory is struggling, what you can do to support their memory, what you can do to support how they process what they see, extra resources, but it's just broken down in a way that the school teacher knows exactly, or the parent, what section to exactly go to support that child. And my recommendation is when you work on strategies and accommodations, you apply it to a real life activity at the same time. So if you're working on chunking, where you're grouping things together for them to remember it, then automatically translate that to spelling words and chunking, something that they can apply it to, so they have that understanding of how they can utilize that strategy successfully. We have a question. Yeah, it's in adults as well. Very good. Okay. All right. So this is just a helpful worksheet, and it's something you may want to keep handy. Generally, what happens when a child's tested for dyslexia, they, like I said, they go to a school psychologist, clinical psychologist, neuropsych. However, sometimes you don't have access to one discipline, or you need to put something together in your community and school. What we're going to do is make a list here, and on your handout, you have on the right-hand side of this slide a place to take notes. And so this might be a good slide to take notes on, and that is writing down what profession can test for each of these areas. So we take a look at spelling, reading readiness, and reading. Of course, your teachers can provide standardized testing for this: psychologist, speech therapist, dyslexia specialist, reading intervention specialist. Those are the three disciplines that can provide testing for those three areas. IQ is typically tested by somebody with a clinical psych background, neuropsych, school psychologist. It's interesting because when you take a look at the WISC, I think I'm going to sneeze. I'm so sorry. When you take a look at the WISC at the vendor, it does say that an occupational therapist can administer the test. I'd be really cautious about administering tests that you may not be familiar with. And there are a few places to check. So of course, you're going to check with the vendor. You are also going to check with your state licensing board to see if it's within your practice act and your scope of practice. You'll also check with your employer to see if they bite off on that too and approve that. So if they do, and you have a green light to go, I would still be hesitant and team up with a mentor, somebody who's very experienced in administering the test, not because you'll need help administering it. I think we're all able to read the instructions and administer it over time, but it's really comes to the interpretation of what you do with that data. So I would encourage mentorship with any assessment that you're not familiar with giving and that you'd like to give. Executive cognitive function skills, the occupational profile, that can be done by anybody. This is gathering that lived experience. Sensory integration and primitive survival reflexes. This is something that you'll reach out to your occupational therapist or physical therapist. They can address these as well. Visual motor, visual motor and visual perceptual skills. This is something you'll reach out to your occupational therapist, as well as a developmental optometrist can work on these skills. Visual and auditory memory. This can be worked on with occupational therapy and/or speech therapy. And psychosocial domain can be worked on by the occupational therapist and the clinical psych, school counselors, and of that nature. So it's important to really have an understanding of what roles can test and what roles can provide intervention and treatment, whether it's formalized treatment or anecdotal treatment. All right. So you have a large copy of this in the material I sent you, and this is a vendor resource list of all the assessments or the typical assessments I use when I am working with an individual with dyslexia. And so what you'll see is information on your left. There is information missing here. So I think there's a second page to this. I will email it out to all of you. I just realized that there's only one page here. Anyway, there's the list on the left that talks about the cognitive function that you'll address, the name of the assessment, and then qualification levels. So you'll see here that you've got a level B on one test and level B on another. They may or may not be the same vendor, but just because it's level B qualifications for one vendor doesn't mean it's the same level B qualifications for another vendor. So you'll need to look at the vendors to make sure. If it's blank or there are no qualification levels, you can administer it. However, again, make sure if the publisher offers training or you know somebody that can do it, you work with them to help mentor you through. The completion time, this is the vendor listed completion time, and I'm here to tell you, expect to spend much more time, especially on those assessments that aren't timed, like maybe the test for visual perceptual skills. You could be there quite a while. So just be prepared for that. And then scoring and where to purchase it and the estimated cost of what that'll be. So there are a few things to consider when choosing your assessments. Everybody will use different assessments. There is no standardization for how to test for dyslexia or how to diagnose for dyslexia. And as you well know, occupational therapists cannot diagnose for dyslexia. It's out of our scope of practice, but we can certainly assess the executive cognitive function that supports dyslexia. With that being said, we want to consider a few factors: time, money, and ability. So as much as we don't like to think about it, budget's really important. So we have to see what's in our department budget to see if it's something we can afford. Some of these assessments are pricey. Some of them require a yearly annual license subscription to score. Will that be in our budget to renew each year? Can we, what's the cost of getting the protocols? Because from an ethical and copyright standard, we cannot copy protocols. We need to use original printed protocols. And so that's an ethical issue that needs to definitely be adhered to. And so there's the budget. There's also the ease of administration. I'm not sure how many of you know or utilize to the full potential an OTA to administer your standardized assessments, but I am a big fan. And typically for efficiency, I will book 2 clients at one time, and I will pull certain assessments for the OTA to administer, such as perhaps the test for information processing skills, the Jordan left right, maybe the scan 3, things of that nature, because they're standardized. And I may do some other assessments, and then we'll swap children and we'll do the remaining assessments. I will also have OTAs score if it is a standardized scoring manual or if they're putting raw scores into a software system. It is cost effective and it saves time. So utilizing an OTA in this capacity not only utilizes the skills that they bring to the table as a COTA, but it's just so much more cost effective. When I utilize COTAs in this manner, I also have a form I created of observations that I like them to write down and complete for me, so I can help use that in my interpretation of my report. So the ease is really important when you're thinking of testing. Also scoring. I think about the handwriting without tears, the print tool. When I first started scoring that, or if I have a really complicated client, it can take me up to an hour to score. Not fun. So I'm not a fan of administering it versus something where you can almost score right then and there, and it's easy. So you want to make sure that it's efficient. Can you do electronic scoring? Is it manual scoring? How long does it take? Because this all cuts into your time, budget, and resources. The last thing you want to think about is, what are you getting out of that assessment? You need to be getting something that either applies to your choice of strategies and accommodations to support your treatment plan. Like, it needs to have a so what factor. And if it does not, or what you are getting out of it is so minimal, you need to ask yourself, is this worth the time I'm investing and the cost to the client and the cost to us to administer it? Or would something else be more efficient? For example, when I take a look at the Berry visual perceptual test, I used to give that and I no longer give that test because in my mind, it's really a spatial awareness test. And I'm not getting a lot out of it, which is why I only use the visual VMI. And then I use the TVPS, the test of visual perceptual skills, to get all the real information I want, because I can get a lot more information, richer data that helps me develop a treatment plan and accommodations than I would from using the Berry spatial awareness. Visual perceptual test. So those are questions you'll need to ask yourself. And when you answer all those questions to your satisfaction, then you'll know if you're making the most appropriate choice for you, your practice, your clinic, and clients. I think there's a comment. I do see a second page on the previous emailed handout. Thank you, Christina. Okay. So on that one, you'll see the tips and a few other things. So thank you for pointing everybody in that direction, Christina. That's great. Okay. All right. Oh, one thing I want to bring to your attention are the PEMCY and the CAPE. I love these assessments. Love, love, love them. So I only administer these once a child enrolls. I do not administer these at the initial assessment. This is my way of finding out what's meaningful to the child. So the PEMCY, this is a questionnaire the parents can fill out. I have them fill it out in the waiting room while I'm testing the child. And it's free, which is awesome. The CAPE, I don't use it the way it's meant to be used. I'll tell you how I do use it. So basically it comes with these cards, and I've laminated them and put holes in them and put them on a D-ring so they're easy to work with. And they're black and white drawings of activities, riding a bike, riding a horse, swimming, what have you. And then the questionnaire in front of me has a Likert scale of faces. Think of the pain scale, like faces of happy, sad, what have you. So for each card, it asks them, how much do they enjoy that activity? They don't, or they love it. You know, it's kind of like on a scale like that. And so I think it's scale 1 to 5 or 0 to 5. And anything that they have a 5, I'll highlight with a yellow highlighter. And while I'm like, I don't even score it because I'm just interested in what are they interested in for the purposes of what I do. Now, if you're looking at engaging them back in that occupation, you may want to score it. I'm just sharing with you how I utilize it for working with dyslexia. So now what happens, we talk about being client-centered and the client's the most important part of the process. So now I have this great resource of knowing what this child enjoys doing. And when I'm in session with them and I'm working on something that they may not be enjoying, which sometimes is everything I'm doing because it's working on a skill they're not, proficient at. Let's say we're working on a spatial awareness activity and they're just really struggling, but they really love puzzles and Legos. And I know that because of this form that they filled out. We'll talk about their puzzles and Legos and how this applies and how they'll see their improvement. And all of a sudden now they have buy-in because they see purpose and it's a value to them. So I use it as a tool to connect with the child and make it meaningful to them. And so I highly encourage it. I absolutely love it. Anyway, just thought I'd share. All right. So let's take a look at an evaluation. You should have received one when you got the email with all the attachments. I'll open it up here and I will blow it up a little. So every single occupational therapy evaluation and every single dyslexia evaluation will look completely different. There is no form, if you will, or format or standardization to do this. So what I did was I took information from several children and put it in this report. So this is not a real person. It's not specific to any one person. I just thought it was interesting to put together. However, it is representative of what an average child would look like that I would typically see and the results we would get. So that's why I put all this together. So we'll just go ahead and read through it together. The reason why I'm seeing this kiddo, they are almost 10 years old. They just finished 3rd grade. Their parents brought them in to see if this particular kiddo has any learning differences. This is a very happy, social, polite child, and but is behind compared to their friends. This child attends private school and participates in a reading program through school services. Their concerns are reading comp, spelling, and handwriting. So just a little background, pregnancy was fine, full term. She did have preeclampsia and was on bed rest. Minimum of 6 months. Within the 6 months, this child did have vision and hearing with normal results. The parent reports no psychological or physical trauma. Prior psychological testing indicated the following comorbidities: dyslexia, dysgraphia, anxiety, symptoms of learning problems, symptoms of fine motor delays, symptoms of an attention expressive language disorder, educational stress. Full IQ score is 95, which is an average range. Characteristic of most concern is frustration, easy fatigue. So something that was in this medical history that I often find, and that is parents report no psychological or physical trauma. And based on their comorbidities and based on them falling behind, I would anticipate there is some psychological trauma here. So trauma is very personal in terms of interpretation. You can have two people that have had the exact same experience, but depending upon their coping skills and their prior lived experience, for one person, it might be traumatic, and another person, they're fine. They're processing it fine. It's not even a problem. But, for kiddos that fall behind like this and are struggling a lot, that can be traumatizing. So just being aware of that. Some parents may not recognize that as trauma. Okay. And then on my website, I have a screener. It's a free screener. And let me bring that up just so you can see that real quick. So you kind of see where we're going with this. If this is ever something you want to use for your client, you can do that. You just click on free screener, and they would fill this out. If you want a copy of it, have the parent put in your email, and then I'll make sure I get you a copy of it. And then you can provide it to the parent. But whatever email in here, that's who's going to get the copy, just so you know. And it's a pretty extensive screener. It's quite long. And what it works on is it looks at some of the basic dyslexia characteristics, but it also looks at ocular motor function, and it looks at executive cognitive functions such as memory, visual, perceptual skills, things of that nature. So it does go pretty deep. But anyway, whatever they wrote on the screener, I'll put that on their report. And the reason I do this is because I'm trying to do two things. One, educate whoever reads this that dyslexia is not about reading and exclusively to reading, but two, to validate the child's experience to whoever's reading this. So it's really important. Okay, hang on a second. Okay. All right. So this is the ocular motor function that this particular child checked off on. And so that's included now as part of the screener. I write a few of my observations that, the child is right-handed. They had a good pencil grasp while writing. This child enjoyed playing with neighborhood friends and riding on their electric scooter. These are the assessments I provided. And then I also provide them with a breakdown of how to read the scores. And I spend quite a bit of time explaining this to parents because I think it's important that they understand the scores. And then I give example explanations below. But basically what we're looking for their scores to match their IQ. So this particular child had a 37th percentile percentile IQ. I think they were in the 95th. Full IQ score is 95. So average range for testing would be in the 25th to 75th percentile rank. This is not percentage piece of the pie, it's percentile rank. So if I have a child that's scoring on any subsequent test in the 25th percentile rank or higher, I'm like, they're fine. If they're scoring at the 24th percentile rank to the 16th percentile rank, I might be concerned if they're also giving me a lived experience that this is a problem for them. If they are not showing any problems, I might put this on the back burner. If they are, it will definitely go on their treatment plan. If they are scoring in the 15th percentile rank or lower, this is definitely something I want to address in therapy, and I'll put them on a treatment plan for it. So let's take a look at how that works. So the first test I administered was the Berry. You'll always see when I write my reports, I explain what that test does, give the scores, and then the takeaways in bold. And it's the same format throughout. I also list the test in developmental sequence. So it goes from the very basic thing and then reading is the last, because that's the highest level of function. So you can see the layers and how it builds and where the glitch is. So let's take a look here. This person has 19th percentile rank for visual motor integration. So let's go back over here. 19th percentile rank is in that low average range. Okay. So the Berry, their report says it's below average. So either way, you have a concern. I rarely report age and grades. And I think it's the Berry scoring manual that tells you that they don't even like putting them in there, but they do it because schools really want to see it. And I will do this if I know how to qualify a child for services, because sometimes the percentile rank will not. But the flaw to this from a treatment plan process is if you take a look at average scores of 25th to 75th percentile rank, and you put that on a bell curve, you know that 25th percentile rank is on that left side and the 75th is on that right side, and it's a pretty wide span. If somebody scores 25th percentile rank on a standardized assessment, their age and grade may be 1 or 2 age or grades below what they really are. And if they're on the 75th percentile rank, it looks like they may be 1 to 2 grades age or grade higher. So it gives the misinterpretation that they are either delayed or gifted when neither is true. They are still average. So I really hesitate putting age and grades in my report because parents get real hung up on that and they think something's really wrong or that their child's doing really great. And I don't want that perception to be skewed. So when it comes to developing a treatment plan and determining if there's a concern or not, I always look at the statistical scores and not age and grade. So then I take a look at the test of visual perceptual skills, and I've mentioned this a few times, and this is a great example of what I was sharing with you. So here we're looking at the overall percentile rank, which is 42. And when we look at 42, we can see that that is an average score because it falls right in here between 25th and 75th percentile rank. So at first blush, we're like, oh, they're great. There's no worries. But if you take a little deeper look, you can see their visual figure ground, which is finding things in clutter. Where's Waldo? Is the 5th percentile. And that their sequential memory is at the 8th percentile. And visual discrimination is at the 9th percentile. These are single digits. So let's go up here. We're looking at below average or lower scores here. That's a concern. So how do they end up with average scores? How do they end up with an average overall scores? Because we have a lot that are right there in the middle. And then we've got this huge 91 percentile rank where they're excelling in form constancy. But it does not negate the fact, I'm sorry, I was looking at scaled scores. I apologize for that. No, these scaled scores are fine. 10 is an average scaled score. We're looking at the 5th percentile rank here. So they had some high scores here. So that's why they're average, but we absolutely want to take a look at the visual figure ground and we want to address that. That's something I would tweeze out, make sure we were addressing in a treatment plan because that visual figure ground should at least be in the 25th percentile rank or higher. Speaking of percentile ranks, this is anecdotal. And I just want to make sure you understand that I have no evidence to back this up other than my own clinical experience. I understand that 25th percentile rank is average, and I respect that. But from an application standpoint, I really strive for my goal to be at the 30th percentile rank because from a functionality and application standpoint, I've noticed from my observation, students, when they're at that 30th percentile rank, there's more automaticity and ease in execution versus 25th percentile rank. They're still a little clunky in that task from an everyday application standpoint. So it's just something, an observation I've made over the years. I shoot for 30. even though 25 is the average score. All right. Tests for information processing skills. This is looking at how they process information that they see and that they hear. It's looking at visual and auditory memory and delayed recall. So we can see here that they've got some significant delays with visual and auditory memory. They're in the 1st and the 2nd percentile rank. Delayed recall is in the 16th percentile rank. So let's take a look at that chart. And the 16th percentile rank is low average, still average, but low. Here's my question I want you to put in the chat in the Q&A for me. When it's time to develop accommodations, if we give this kiddo extended time, and on Monday, we give him 13 colonies to remember. On Friday, he's going to have a test. And Friday, the class is given 10 minutes to take that test, but he's going to be given 20 because he gets extended time. After the first 10 minutes, he gets 9 colonies. Do you anticipate, if you give him the extra 10 minutes, which is that delayed recall, because it's been a week, now we're giving him extended time, do you anticipate that he will get the remaining 4? Yes or no? I'd love to see your responses in the Q&A. So Roxana and Joe both say no. You are absolutely correct. But this is interesting. We have a very interesting audience here. Most of you are occupational therapists. However, when I have a mixed audience and I have teachers in the room, they will say yes. And so I need to bring their voice to this conversation because you are both right. From a teacher standpoint, they are told if you give extended time, that's the best thing you can do for the child. But from an occupational standpoint, occupational therapy, we know that from a neurological standpoint, if they don't have the ability, then it's not going to help. So giving extended time in this instance is not beneficial. And our expectations would be that they would not remember the colonies. So if their delayed recall was improved to say 25th percentile rank, would our expectation that they could get those remaining colonies be higher? Absolutely. Right. So it's not saying they will never do it, but it's saying that until that delayed recall has improved, giving them extra time is not supportive, because in our good intentions to support them by giving them extra time in this situation, we're actually chipping away at their self-esteem, their self-concept, and their negative self-talk starts spiraling. I'm dumb. I can't do it. I'm stupid. I'm not good enough. It all starts to spiral. Same score, different scenario. This child really struggles with decoding or sounding out words. You want him to read a passage and then tell you the answers to questions as soon as they're done reading the passage. The first time they read the passage, they're struggling sounding out the words and they sound very robotic. The second time they read the passage, it's a little more fluent. The third time they read the passage is the first time they're really understanding what they're reading, because all their attention was given to decoding and fluency the first 2 times. It takes this person longer to read than the person next to him, because this person had to read it 3 times. So now that he's been reading, we're going to ask some questions. In this scenario, is giving him extra time going to be helpful? What are your thoughts in the Q&A? Yes, absolutely. Because now we're talking about immediate memory, right? And so at that point, giving extended time would be beneficial. For this particular child, it may be rough all the way around just because the scores are so low across the board. But in general, when we're talking about that delayed recall, we need to really make sure We're going back to our assessment to see if they have the foundational skills to even do it. And that's what's really important. So for example, let's backtrack here. We have difficulty with figure ground. So asking this kiddo to find the colored pencils on the bookshelf and then being frustrated when they can't, we can't be frustrated at them, right? This is an area they struggle with. And so we need to just kind of keep that in mind. And I think this is really important when parents are thinking about disciplining and managing their own expectations and frustrations at home. We need to know what the child is capable of doing. So then we know, do we need to provide support or redirection or structure? What do we need to do? Is this something that they deserve a consequence for, or is this something that we need to provide support for? Okay. The next assessment is the Jordan left right. Now I have a little story to tell you about this particular assessment. It was new to me. I think I practiced for, I don't know, 8 years or so, and I had never used it. And it's due to workshops like this where therapists in the audience kept recommending it. So I started using it. And I think it has about 5 subtests. If they are under 9 years old, they do the first 2 subtests. And those first 2 subtests, they just identify letters that are backwards or pictures that are different. But the rest of the subtest, if you're 9 or over, are words or sentences, and they have to identify letters that might be backwards. Well, what I've noticed is if they're 9 or older and they're having difficulty with reading, they often struggle because they're trying to read it. And so I'm not sure if it's really a reversal issue or if it's a visual perceptual issue. So I love the robust data I get when they're under 9, not a fan of over 9. So that's just my bias of that. And that's our job as a clinician, as a provider who does testing, is we see those scores and then we need to interpret and apply them in reflection on the whole story of the child and what else is going on. Then we take a look at the CTOP, and this is looking at emerging reading skills. So phonological awareness, this is the ability to associate sound with letters and different letter sounds and combinations together. And we want composite scores to be 90 or above to be average. Phonological awareness is made up of lesions, blending words, if you know me, isolations. Lesions is, there's a word, now we take a sound out of the word. What's the new word? Blending words is taking different parts of the word and putting it together. If you know me, isolation, where is the sound located in the word? And so we can see here that they're really struggling, but because these 3 subtests make up phonological awareness, we know we need to focus on lesions and phonome isolations. But here's the question. We know they have difficulty with auditory memory, but down here in phonological memory, their memory was well within reason. So since the memory was in reason, is the reason they struggled here due to auditory processing? And again, this is where you have to go through that checklist in your mind and go, do we refer them to an audiologist at this point? That may not be a bad idea. Then we took a look at rapid symbolic naming, and this is really looking at processing speed. They have to read numbers as fast as they can and read letters as fast as they can. Activities I like to support this: Simon, Bop It, Spot It. Any type of activity that's timed, a game, is really good for processing speed. Then we took a look at the Wyatt, and the Wyatt is a massive assessment, but for this particular child, I chose just to do the dyslexia index score, which is a screener. Remember, we cannot, as occupational therapists, diagnose dyslexia, but we can administer the screener and we can refer for full-on diagnosis by a clinical psychologist if the parents would like. And so again, we're looking at single-digit percentile rank scores, and this puts the child at a very high risk for dyslexia. I do use this test right here to place them in spelling of what grade level they are. I do use the grade level for that. Okay. Now we're taking a look at the GORT. This is a reading out loud type of test. I really like it because it gives me an idea of what the reading issues are. This is really typical to see comprehension score higher than the rest of the scores. And I think it's because if they read it and they don't know the word, after 10 seconds, I can give them the word. And because it's out loud, it helps them with comprehension. So this person is having difficulty and all the way across the board, but they also are having difficulty with several things that lead up to that. So they're having a delay with visual motor coordination. They're having a difficulty with visual figure ground. So are they even seeing the word the way they're supposed to be seeing it? They're having difficulty with visual and auditory memory, which may impact what they're reading because maybe they're not remembering what they're reading when they go to answer the question, or maybe they don't remember what that word is. They're having difficulty with phonological awareness. So are they even decoding the word right? They've got auditory memory issues. Are they forgetting the sound associated with that letter? Is it auditory processing? And so you can see how all these foundational skills are low. And if we were just testing for reading, we wouldn't have tested all those other things and wouldn't have had an opportunity to go back and provide support. So it's really important to provide that support. And then I go ahead and write out the strengths. And these are all the areas that were average or above, and anything that was average or below, I'll write those strengths. Because of the dyslexia index, I could say that they are at risk for dyslexia. And I always write, this is an impression. I don't write that it's a diagnosis because, again, we cannot diagnose. And I even make that statement down here. So whoever reads this report is understanding that this is not a diagnosis. And if they want a diagnosis, they can pursue testing, additional testing. I write additional considerations because there are other things that can make a person present like they have dyslexia when they don't. And that is if their IQ is extremely low, we're talking in the 60s, could it be lack of other cognitive impairment? If they've had trauma, that can block how the language processing centers of the brain works. And so seeking out a trauma-informed therapist would be really beneficial. Are they having sensory issues? That can be distracting them from being able to perform well in these assessments and give a false indication of dyslexia. And so those are all things to be considered. And then I will go over what my plan might look like. And then I present them with their accommodations that may be helpful for that particular child. So that is an example of a report and how I go through that process. If you have any questions, go ahead and put them in the chat. There aren't any right now. We'll get back to the slide. All right. So I use this document when I have conference with parents. Often, if a child has dyslexia, so does one of the parents. And so going over this report with them can be very overwhelming. Starting with a picture is usually much easier. And I can also use this as a report summary, meaning you will see all the areas that were tested on this report. And if I think the child scored below average, I can take a pen and write minus by that area, or if they scored average or above, I can put a plus. So now parents know what areas they need to focus on, and they know what disciplines they need to seek services from. So we start here at the star, and don't ask me why I started at the bottom and worked my way up. I have no rhyme or reason for why I did the diagram the way I did, but I realized this is probably backwards from how normal people would do this. But anyway, it's how I set it up. And things to keep in mind, again, that lived experience, self-esteem, confidence, that grit, we need to see where they are with all those things. Underlying things to keep in mind that we're not necessarily testing for, but could impact the scores would be visual acuity, Ehrlich syndrome, visual tracking, eye teaming, who can treat these things, who can assess these things. The occupational therapist and developmental optometrist could look at visual perceptual skills, visual motor. Occupational and physical therapy can look at the reflexes and sensory processing. If you'll notice, the arrows are going in a developmental sequence. So what I mean by that is if you have deficits here, you cannot start treating here with reading. You have to start treating where the deficit is indicated. That's really important. And then So if there's deficits in the visual, perceptual, visual motor, or reflexes, sensory processing, I may start them off with occupational therapy. And if they have visual sequential memory, again, I may start them off in occupational therapy or the developmental optometrist. And once they score average or above in all of these areas, I may move them over to speech, or I may keep them in OT and also work on auditory sequential memory. If they're having difficulty with auditory memory, I have to think about, do they also have auditory acuity or auditory processing disorder or difficulties? So these are things in the back of my head I may not be testing for, but oh, could this be an indication of why the test results are the way they are? So once they score average and above in all of these areas and we move them from occupational therapy, we may want to transition them over to speech or a teacher or reading specialist of some sort, certified language therapist, to work on phonological awareness, phonological memory. And then once they achieve average or above in these, they may transition off the speech therapist and work with a reading specialist. So that's how I use this diagram. It's just kind of a flow on how I would lay out that treatment plan, what discipline the child will be connected with. And I provided you with a full-size copy of this in your material, so you could use this as well. Parents really seem to appreciate it when I print this out and go over it with them. I put their child's name on the top date. And it's just a real nice, easy way for them to take this to their school or to the provider and say, this is where we need support, and then hand the report as well. It brings the parent into the conversation. Okay. So again, we talked about six steps to working with somebody who has dyslexia. The first one is meeting them where they are. It's that psychosocial component. Observe and gather. Finding the right path. Do they need to go to reading intervention right away, or do they maybe need to have testing by the therapy team? Build your team and evaluate who does what. Are we sending everybody to the psychologist at first, or are we sending some to the psychologist and some to OT or speech, or we don't have any of those services? Maybe we need outpatient. Are we just doing observation? So you'll have to think about how you want to outsource all of that responsibility and use your community resources to your best. Okay, we are moving pretty quickly today. We are doing really well. We will most likely finish before 3 p.m., which I don't think any of you are going to be too terribly sad about on a Friday. Okay. So you have this document in your resource as well. This is just a few things of treatment material that I've used before. Like I said, there's no right or wrong. There's no standardization. I am very, very old school. And you'll notice, you'll look at this material and you will be impressed and underwhelmed. My area of expertise is in traumatic brain injury, and that's where I started my career. And because of the success I saw in hands-on material, I've stuck with that. I've had the outcomes to show that this is really effective and works. I have vacillated back and forth between using, programs that have a computer license. I don't see any real improvement. In fact, I see a disconnect. And I just think it's because our children don't get a lot of in-person one-on-one connection. They're either on devices or they're in a group with other children. They're in a family with other children. They just aren't getting a lot of that I'm here just for you time as much as kids used to before technology and social media hit the scene. So I find real value in hands-on one-on-one activities. And that's what's listed here. And I just wanted to give you my why for that. This is set up very much like the original, the assessment document, where the cognitive function you'd like to work on is listed here on the left. What's the name of the material that you're going to be using, vendor, where to find it, cost. So we are going to go over an example of all of these things. And I think I sent you an attachment that said Dyslexia Lab, and that's going to be a few of the examples of what we're going over. So you have a full version of it. Some people like to print those out and just use them. I caution you about doing that because I only took one page out of each thing. And each book that we're using, when you flip the page, it grades the activity up. And when you go backwards, it grades it down. So I would be really cautious in using that one thing over and over and over. The other thing is you'll see on the upcoming slides something like letter tracking, and then you'll see a form and somebody will ask me, where do you get that? And I'll refer you back to this paper where it will say letter tracking, and then it gives you where to buy it. The other thing to think about is I have several things here, like the help manual, no glamour memory, fine tuning, all listed under auditory memory. It doesn't mean that this is the only thing you can use it for. It just means this is what I use it for the most. You can adapt any activity to anything you want it to be, change the instructions slightly, modify it a little bit, and now it addresses an entirely different cognitive function. So, and I think as OTs, you're pretty skilled at that, but I just wanted to let you know that. I'm trying to think if there's anything else I want to share with you about this. I think we'll hit on it. Okay. Okay. So Hannah wants to know, what would you recommend if we wanted to work on improving retention and working memory? So Hannah, great question. That would come under the help book. We're going to go through every one of these books and we're going to spend time working on them. And if you've printed out the lab book, you can do pencil paper activity with me and actually do it with me. If not, you can at least see how it works. So let's go into that. There we are. My cursor was stuck. All right. Before we get into the details, I want us to talk about how we build a neuropathway. We talked a lot about neuroplasticity and neuropathways, but we haven't really talked about how to build one. And yes, that is my artwork. This is why I had to go to college. I have no skill, but I drew this picture a million times when I first started working with parents with dyslexia. And so it's near and dear to my heart, and I couldn't not have it in my presentation. As old and outdated as it looks, it's staying. So what you see on the left is an axon. And one axon will connect one dendrite. No, one axon will connect with a dendrite, but a dendrite you can see here can connect to multiple axons. And what happens is an axon's just kind of hanging out. And when you overload it, it says, oh, I need help. And that's when it starts reaching out to the dendrite. And when they connect, that's when a synapse happens. That's your new neural pathway, or your expressway system, if you will. And so that is building a neural pathway. The more you build, the faster somebody can process information, the more memory they can hold on to. So how do you do that? You can do it through the CAPE method. The first thing you need to do is give yourself a challenge. So the example I'm going to use is, I want to lose weight. And so that's my challenge. And then I need to take action. Okay, so I'm going to get on my Peloton and I'm going to exercise. So I get on my Peloton, I exercise. But then you need to practice, meaning you need to do it over and over and over. And that's usually where I kind of fall off the wagon, right? And after you practice or some time goes by, then you evaluate. Evaluating can be very different. I can evaluate by getting on a scale. I can evaluate by taking measurements. I can evaluate by how physically fit I feel. I can evaluate by how my clothes are fitting, but there are a variety of ways to evaluate. And at that evaluation point, you will decide, I have met my goal. Nothing's changing. So what do I need to adapt? I'm plateauing. Do I need to adapt? And then you come back again to the challenge. Now you're making your modifications. Now you're doing action. Now you're practicing and you're evaluating. And it's staying in that loop that helps you develop a neural pathway. So again, we want to meet them where they are. It's that psychosocial component, observe and gather, finding the right path, why somebody goes to reading intervention versus someone receiving therapy services, build your team and evaluate, develop accommodations and strategies around strengths, plan therapy, treatment to change weaknesses to strengths. So what does that mean? It means that if you have somebody that has strong auditory memory, then you want to make sure you use strategies and accommodations that work on verbal or auditory strengths? Can they record a lecture? Can somebody verbally give them the instructions instead of them reading them? Things of that nature. And then let's say their visual memory was below average, then therapy would wrap their arms around that concept, and they would work on activities and intervention to increase their visual memory. All right. So what we are going to do for the rest of the day here is we are going to go ahead and take a look at an executive cognitive function, what that function does. The next slide, we'll talk about what activities we'll use and how to use it. Then we'll watch a video of it being used, and that's how this will go for the rest of the afternoon. All right. So the first one we're taking a look at is figure ground and visual tracking. Who can remember what these work on, or how would you work on these in your practice? Anybody remember? Okay. So figure ground, this is finding Where's Waldo, finding things that might be in clutter. So we have visual figure ground, and that's what we're talking about, but there is such thing as auditory figure ground. And this is something more on the speech therapy side. An auditory figure ground, I want you to think about going into a coffee shop and trying to focus on your work. Some people thrive on that. Me, I can't get anything done. I can't differentiate all the noise. Or think about you're eating at a restaurant. Can you filter out everybody else's conversation to be able to understand what the person sitting right across from you is sharing with you? That would be auditory figure ground. Visual tracking. Think about reading left to right or right to left if it's Hebrew. Think about not skipping lines. Those would be visual tracking skills. Yes, Vanessa, I Spy, work on ocular motor tasks. Absolutely. That's a great activity. And as we are coming up with activities, if you want to write them in the chat, and I'll share them out loud so everybody can start making a list of activities that they might want to use, and you can help each other, because I guarantee you probably have a ton of resources where you work that I haven't even thought of that would be a benefit for everybody else to hear as well. All right. So for figure ground and visual tracking, we can use letter tracking. This will promote that left to right reading, processing speed, because you can time it. And here's an example. Okay. So I'm going to show you a couple of things. You're going to see the video of how we use this for therapy, but let me just give you an example of how you can use this if you want to teach a strategy. If you want to use this to teach a strategy, you could get a piece of paper and cut out a tiny little slit. And so everything is covered up except what you can see through the slit, and they may only read one line at a time. This might be a great strategy to use until their visual tracking is strong, so they can use that strategy so they can keep up with their reading assignments in school right now while they're working on that skill in therapy. Another way to make this into a strategy, you can draw a hot pink line going down the left vertically and maybe a green line going down the right vertically, and you can have them start with their pen. And as they're going over, they have to go from the hot pink line all the way to the green line and touch both lines so you know they've gone from side to side. Those techniques would be a strategy. When you are using a strategy, this is really important to know, you are not building a neural pathway. When you are using a strategy, you are not using a neural pathway. It is a Band-Aid over the issue, and they need it to get through today. So please be intentional about the instructions you're giving and why you're giving them, because if you think that that's building a neural pathway, you're going to be very disappointed when their scores never change and they continue to be frustrated. And if you take that strategy away, they can't do it on their own. So they need a balance. Remember that triangle we showed? They need a balance of strategies and therapy intervention. This is an example of how you would use it as a strategy. And once they understood this strategy, then you would have them apply that strategy to a real book they were reading. Remember, I told you to have that direct application. Now we are going to watch a video on how you can use this letter tracking as a treatment intervention.
So I
Hang
just want
on.
you to find your ABCs in order from beginning to. So I just want you to find your ABCs in order from beginning to end. And just whenever you're ready, you can start. Great.
Okay, can anybody take a guess as to why I had them? A couple of things. Why am I using a dry erase paper? I have loads of questions here. Why am I using a dry erase paper? When is it inappropriate to use a dry erase paper? Sheet protector is what I'm calling a dry erase paper. And why am I having them go under the line, circling the letters from left to right all the way through? That's a lot of questions. Any ideas on any of those in the Q&A? An aesthetic for protector, easy flow, and keeps a nice flow. Any other ideas? Any other additional ideas? All correct answers. Cheaper. I love that. Yeah. There's something to be said for that. Yeah. Dry erase makes it under, okay. Lots of good answers coming. Saves paper. You can reuse the paper, left to right reading. Use again, recycle, reuse, reduce. Can be erased. Dry erase makes it easy to move. Yes. All right answers. And I'll also add to that with some additional information. First of all, I use a dry erase. Exactly. It's cheaper. In the manual, it says it is reproducible for therapy. So in that case, I'm not violating copyright. It is only appropriate to use when they have really good fine motor control. If they do not have good fine motor control, I may have them just use the paper without the dry erase and use chalk, because then I can still erase the chalk if they make a mistake and I can go back to where their mistake is. So let's say she missed this letter here and then she's going rows without circling anything. I can then take an eraser and erase the chalk and have her start here again. So chalk is usually my go-to on this. If they're really little, they may just want to use a crayon. So if they don't have good fine motor control, I typically will not use a dry erase, just to kind of know that. But the reason I'm having them use, how do I word this? The reason I'm having them circle like that and go all the way from left to right is so I can see their visual tracking. Because if I don't, they may circle letter here, then come down here, circle letter, go over there, and they're all over the place. So it just helps teach them that left to right tracking. So those are the reasons why, and all of you got that. That's right. Very good. Okay. So this is being used for visual tracking and figure ground and processing speed. So about the timer, all these videos that you're seeing are training videos I had for my staff. So they're all adults doing this. And that's why the timer's there. However, when I am working with an actual client, I never have the timer out for them to see. It's on my lap, it's behind something, it's out of the way. And I never say, ready, start. I never tell them when to start. because that's anxiety producing for them. I always say, start when you're ready. And when they get that pencil on the paper, I start the timer. It's just something to help reduce their anxiety. Okay, symbol letter tracking. This is very similar to letter tracking. What I like about this is great for somebody who may not be a reader. So we have symbols. We have this set right up here that goes to this paragraph, and this set goes to the lower paragraph.
How are you doing today?
Hello.
Okay, today we're gonna work on figure ground skills.
Okay.
And what we're gonna do is we're gonna look at these three symbols.
Okay.
And we're gonna go down the line. We're gonna start right here, and we're gonna go down the line, and we're gonna circle each symbol as you see them sequentially in a row.
Okay.
And you're just gonna keep going down the line,
Okay.
and we're gonna time it. So,
Okay.
are you ready?
I'm ready.
Okay.
All right, so visual closure. This is one of my favorite books. I love this book. It basically, I love it because it's very gradable. So the book comes and the pages look like this. And what I do is I take each page and I run it through the copier just like this. Then I take white out and white out all the dots and run it through the copier like this. Then now I have two of the same pages, so to speak. Then I'll run them through the copier on blue paper or some type of visually discriminating type of paper. And then I put them back to back in a sheet protector, because what I will do is I will have them do this page first, and I want them to do everything in symmetry. And if it looks like it's good symmetry for their age and their ability and their skill, then I'll have them do it again without the dots. And I want that same image symmetry. And if I get that, then they move to the next one. So this is one of my most favorite books to use. I haven't found anything out there that works on visual closure as well as this. When you're thinking about grading an activity up, all of these designs get much more complicated as you turn the pages.
All right, today we're gonna be working on half and half. To help us increase visual closure. What we will do is you'll take your page number, which is page 14. Open your half and half book, page 14. What I'll have you do for me is we're gonna mimic that top design. So you have your first half. Now we're gonna do the second half. So I'm gonna do this. So we're gonna trace it as well as we can. Now the process has been completed correctly. You'll go to here, you go to H&H, and you'll write. Okay. That's it.
All right, so just a minute there. I know it's kind of blurry, but I used this. This is a private practice clinic that I had that I was using this material in, and we were private pay. We also took insurance at a time, but we were also private pay. But this is what I used for quick notes to get through a session. And every piece of material that we had, I had written on this piece of paper. And then in red ink, was the assigned work the person had to do. And then the clinician wrote the scores in green ink. And when you were looking at, let me see if I can back this up a little bit. I don't know if I can.
Today we're going to work on half and half. It helps increase visual closure.
The video is not letting me.
All right, today we're going to work on. Another.
Right there, you can see it maybe a little better, but you can see right up here where they're working on visual discrimination book, and I have the word visual discrimination up there, visual perceptual up there, auditory memory right there, visual closure right there. So spatial relationships is written right there. So you can see the executive cognitive function that skill is supposed to work on. And so this is where they put kind of their Cliff Note version of their notes, if you will. And then if we were using electronic medical record, they could go in and write their narrative or write their formal note to bill insurance, and they knew exactly what activity was working toward what executive cognitive function, so they could write their note, and then we would send it on for billing. But what I loved about using this form, my goodness. So word retrieval is my issue if you haven't caught on to that yet. So thank you for being patient with me. But what I loved about this form is, as a supervising OT, there was one form per session. They came once a week. Some came twice a week. Some came every day, or whatever their frequency was. But I could look back once a month or once a week, or however often I want to look back, and I could flip through all their notes rather quickly. And I could see, wow, they're stuck on this one activity for way too long, or they're advancing really well, or they're a slow burner. They're really taking a long time on this. But it was inevitably like the best thing on the planet. It was gold when, in the rare event, we had a student on a reevaluation score lower than the initial or not make improvement. On occasion, that happened. It's your worst nightmare as a clinician. You've been seeing this client for all this time, and they're making no progress. And it is the worst feeling. I know for me, it's the worst feeling than having to explain that to the parent. I have learned to rely on these prior notes because I can easily see where they were stuck and why. And the therapists usually do a really good job of writing things down. They were inconsistent with home therapy, or they were inconsistent in attendance, or this particular skill they're improving, it's just a slow improvement, and this is why. But it always gave me a great way to explain where the deficit is and why they're not making improvement. So that's why I was using a document like that. And I thought I'd just share that with you, because you'll see that in several of the videos. Okay. Back to our regular programming. Visual tracking. So this is keep on tracking. This is something that you've seen in a million workbooks. You don't necessarily need the keep on tracking book. This is something you want to think about age appropriateness with. This is something you can adapt a million different ways. You can time it. You can use a thick crayon, a thin pencil. You can make up rules where they can't touch the lines. They can't go over the lines. Whatever you want to do, this grade this higher and lower. They can color the cars, things of that nature.
So today we're doing KOT, which is keep on tracking, and it's to work on visual tracking. So what I want you to do is I want you to start here and go all the way through and here, and I want you to stay in the middle of these two lines. Just whenever you're ready, you just start. Okay.
Notice how this particular therapist is not timing it, because we're looking at fine motor control. We're looking at left, right. But if you wanted to work on processing speed, you could certainly add a time component to this activity. And then you can decide when they've met that criteria. Maybe you want them to do it in 30 seconds or a minute and a half. and then you give this to them over a multitude of sessions and you're wanting that time to decrease, that would be a way of measuring their processing speed or how well they're doing on their fine motor control.
We'll just mark it as okay. The page number should.
Okay. I love these books, Reversing Reversals. This is looking at spatial awareness, and each page is a little different. So this is just an example of one of the pages. You can see the benchmarks we have here. We want them to do 13 rows of letter sequences, benchmarks 15 seconds. People ask me how I come up with my times and my percentages. I think it's just from experience that I know they have to hit a certain benchmark of percentage or time to be able to show improvement on standardized testing when we retest them in 6 months or a year or whenever that time frame comes around again. Here's my question. Can this activity work on I'm thinking here. Let me read the directions. See how quickly you can find and draw a slash through the letter B. 7 times in each line. Search from left to right, use a timer to measure speed and record time on the blank next to each line. See if you can improve your speed. What visual perceptual skill are they working on in this particular activity? Find and draw a slash through the letter B. What visual perceptual skill are they working on? Go ahead and drop it in the Q&A. Just according to the directions, there's only one visual perceptual skill they're working on. Find the letter B. The only visual perceptual skill they're working on, Roxanne, you got it right. It's figure ground. That's the only one they're working on. My question to you is, could you adapt this activity and have it work on form constancy? Yes or no? Can this activity with different directions work on form constancy? Yes or no? Go ahead and drop it in the Q&A. So one person said yes, and the other person said they're all the same form. And Roxanne, you're correct. Since they are all the same form, you cannot work on form constancy with this particular activity. So that's why it's really important to be intentional about what is your goal? What are you focusing on? Why are you pulling the material that you're pulling and putting it in front of them? And what is your desired outcome? So the way the instructions read on this, the only executive cognitive function you're working on is figure ground. Because it is a timer, you're working on processing speed. But you could also work on visual discrimination because they're having to discriminate between what is a B, what is a P, what is a D. So that's kind of like an underlying unintentional bonus here. So even though it's intentionally only working on figure ground, you could pull it for spatial awareness or visual discrimination. Okay. Just kind of keep those things in mind. So you can adapt a lot of these activities to make it something else if you like. Very good.
Take 4. Action.
Okay, today we are going to be working on a rev activity, and I want to see how quickly you can find and draw a slash through the letter B 7 times in each line. I want you to start right here and work towards your right in each of the lines.
Okay.
I want to see if we can improve your speed. Okay, I'm ready to start whenever you are.
Okay.
All right, ready? All right, you did that in 5 seconds. Will you write a letter 5 or a number 5 right there? Sure. All right, are you ready for the second one?
Yes.
All right. Reset my timer. Ready? Go. Nice, you did that in 5.5 seconds. Put a 5.5 for me. All right.
All right. So visual discrimination. This is the ability to recognize items that are the same or something that might be different. So we're going to use the VizDiz book. This is a book I typically probably would not use, for visual discrimination. But the reason I love it for dyslexia is because it focuses on reading. It's looking at the most confusing words that are used interchangeably. And as the book goes on, the words become more complicated. This takes about 5 to 10 minutes for a student to complete.
Okay, today we are going to be working on visual discrimination. We're going to work on the words was and saw. On this first prompt, look carefully at the difference between each word. Can you tell me the differences between the 2 words?
This one starts with a W. This one ends with a W. This one ends with an S. This one starts with an F.
What's the same in them?
The A.
Nice. All right, right here in the second prompt, I want you to trace each word below several times, saying the letters as you trace them. Okay, and then read the word for me.
W. A. S.
Was. Nice.
S. A. W.
Saw. Nice. Okay. I want you to come down to prompt 3 and write the correct word on the line in each sentence below using was or saw. Okay. Start with number 1 for me.
Jack blank playing on the swing. Jack was playing on the swing.
Nice. Number 2 for me.
I saw you at the store. Dad was in his car.
Nice. 4.
We saw the pretty sky.
Awesome. And number 5.
The clown was very funny.
Awesome.
Okay. And then down here, it's almost like a figure ground activity. You'll see was and saw, and they have to circle the word that they're looking for. And then they have to write was 5 times. They have to create them in sentences. And that's what the rest of this handout does. And you can see that there. This is an activity that they will have to read at a certain level to participate in. And when I do this activity with children, they love making up sentences. And I've heard some pretty good silly sentences. So I had one little girl that was obsessed with pigs. So her goal was every single sentence she ever wrote was to have a pig in it and have it about a pig. So some of them ended up being pretty funny. Okay, visual perceptual skills. This is more of a spatial awareness test, and not test, but activity. And so you'll have pages that either have 5 dots, 25 dots, 30 dots, 9 dots, and they'll see a pattern. And I don't know if you can see it, but there's number 1, number 2, number 3, number 4. There's 10 sets to each section. And what I typically do, you can see here pattern 11, level 1. I'll have them go through all 10 drawings with number 1 on top. And then maybe the next time they come, they'll do all 10 drawings, except maybe I'll rotate this so the 2 is on top, and they just keep doing that. So let me give you an example.
Okay, so today we're going to work on fast, and this is for visual perception. If you look here, we're doing level 1, pages 11 through 14, angle 1. So this just means that the number 1 will be right side up to the clients. So if I could just have you copy this over to this and try to keep the lines as straight as possible and hit the middle of lines, the middle of dots, sorry.
So I do want them to hit the middle of the dots. I always try to explain this needs to be done on a hard surface, not on a pillow, not on their bed, not in the car while they're driving. There's a visual motor integration book that you can also use that does the same thing. And so the reason why this is important is this helps with handwriting and with them being able to interpret what they're reading. But you do want those lines nice and straight.
And this line.
No, that's great.
And if I were to give you $1 million to make it straighter, would you make it straighter?
Yeah.
Okay, so I want to pause there for a moment. The line is crooked, and the therapist noticed that, but the therapist didn't say the line was crooked. I think what's really important is that we empower our clients to do their own analysis and identify what's going on with their work to increase their self-awareness. So when they're in class or doing schoolwork or outside of the environment of working with you, they have the ability to problem solve on their own. So she asked the client to show her the difference between what he wrote versus what she had in the picture. And he said the line's crooked. So she said, you know, would you make it straighter? Or the preferred response I'd like to hear is, can you make yours the same? Can you make it look like the picture? And then see what that interpretation might be.
And then over here, we'll just mark it as open.
Okay, we are getting really close to breaking for lunch. Okay, so I'm going to stop it right there and let you know we are way ahead of schedule. And I think one of the reasons why we're so ahead of schedule is because one of the challenges of doing a webinar or a virtual presentation is we just don't have that real organic Q&A like you would in a live event. So with that being said, I think that's why this is rolling along on time, but I know the questions are there. So please make sure you're asking questions, post them in the Q&A. We are going to take lunch here in just a moment. And let's see, I'm going to just welcome back. I hope all of you had a chance to grab a bite to eat, have a refreshment, and just kind of take a break for a minute. We did have one question that came in over the break, and that was from Vanessa. Can you give me some ballpark estimates on frequency and duration of treatment protocols and each intervention? So typically, I do 1 or 2 pages a session. Our sessions are about 2 hours in duration once a week. Sometimes they are 1 hour twice a week. I do have fast track where kids come in every day for an hour. So remember, this is a private practice clinic, private pay. So we have the luxury of having those long sessions. So that's typically how I ballpark that. Of course, that would need to be adjusted based on what your payer source would approve and so forth. For students that came to see us only once a week or twice a week, we often gave home therapy. And those were activities that they could do at home in between sessions to work on the same skill. And I did give you a PDF of some home therapy suggestions of activities broken down by executive cognitive function or areas that they would work on. We typically recommended no more than 10 to 20 minutes of home therapy a day, realizing there's a million other things that they need to do to get through a day, and we didn't want to pile on too much. So, Vanessa, I hope that answered your question. Let's go ahead and pick up here at spatial relations. Remember, where is a object in relationship to something else? So think about the example I gave earlier of a lowercase p as in Paul, D as in Delta, B as in Bravo. Where do you put that little curve against that little line? Would be spatial relationships, or even putting together puzzle pieces. Tangrams is a perfect example of a spatial relations skill or activity. So I'm going to jump ahead to this one. What you'll see, this child, I believe, is a 4th grader, and I'm working with this child, and I typically, there's a million tangram puzzles you can buy out there. This is just what we were using at that time. And I typically will have the pattern lay on one side, the pieces laying on the other, and they're building the puzzle right in front of them. I do that so they have to go left to right, cross midline from a visual standpoint. What I want you to be really mindful of here is the cues that I am giving this child when I see that, oops, my mic, hear me. I just realized my mic wasn't in front of me. I realize when I realize they may have not done something correctly and how that cue is done. So I want you to keep an eye on that. I also will ask this child when he's completed if his puzzle looks the same as the design. And I want you to kind of count how long it takes him to answer and let me know in the Q&A if you thought that was an excessively long time, or if you're like, nope, that's great. That's about, the appropriate right time that it would take him to double check his work. So let's go ahead and take a peek at what he's doing. Okay, you can see he's putting it in the wrong place. Show me where this piece is on your puzzle. Okay, and then what touches it? What's on this side of it? Oops, I didn't mean to stop it that much. Okay, so what you noticed was I went over here to the correct puzzle and I asked him to show me where that piece was, which was this corresponding piece. And I did that just to make sure we were all oriented on the same page. And then I narrowed his visual field by just asking him what was against this side. So now he's not looking over the entirety of the puzzle, but just this specific side. So I've given him a prompt of how to self-correct. Let's see what he does with that. Show me where this piece is on your puzzle. Okay, now what touches it? What's on this side of it? There you go, you got it. Okay, so now you'll see that he puts another piece in the incorrect space. I give him time to see if he can correct it himself. Since I've already given him one prompt, I want to see if he can carry that over and analyze his own work.
That way you don't have to stop, because it looks like you stop there. Because all connected. Very I think what happened is you stopped and you dotted your I into.
Is it the same?
Okay, so go ahead and trace that.
Good job.
Okay, so I asked him if it was the same, and it took him 10 to 12 seconds to give me that answer. So in the chat, I'm sorry, in the Q&A, please let me know if you think that was too long or not long enough. So Steve asked a great question. Is there research to suggest that working on visual perceptual skills in OT boost reading or helping kids with dyslexia or fluency comprehension? So Steve, at the end of this presentation, you'll see on the PowerPoint handout, there are several evidence-based peer-reviewed journal articles. There are some that are on visual perceptual. So you can take a look at those and read the evidence that shows. And there absolutely is evidence that shows that addressing visual perceptual skills help with reading success. I want you to think about this the other way around. If you can't differentiate between a B and a D because you don't have spatial awareness ability or visual discrimination ability, then if you don't have that ability, are you going to read words correctly? Most likely not. So if you can't read the word correctly because you can't differentiate between a B and a D, then your reading comprehension and reading fluency will be poor because from a visual perceptual side, you're not even perceiving it correctly. So again, visual perceptual skills do not cause dyslexia, but they significantly impact it if they are not at that average or above level. And there is a significant amount of research that demonstrates that. And I really encourage you to read that to help just take a deeper dive and maybe answer your questions more thoroughly. But that was a great question. Thank you for asking. And Steve, you bring up another point. So when I was doing research and trying to figure out just for my own evidence-based practice, what areas am I testing for dyslexia? What do I even do? Because I knew nothing about dyslexia. When my daughter was diagnosed, I don't even think I knew what the word meant. So I was really starting from scratch, and nowhere in our OT curriculum, either OT or OTA, is there a standard to address dyslexia, nor is it in our textbooks. However, AOTA has plenty of position papers that show that OTs work with dyslexia. So there's this disconnect. I found myself first looking in the area of education and looking at the dyslexia programs that they developed. And even though their programs did not address visual perceptual skills, when I looked at the evidence that they were using to support the programs they were implementing, you could see they were testing for these areas. So then I found myself going to the field of psychology, going to the field of speech language pathology, going to the field of optometry, going to the field of occupational therapy, and pulling all this together. And they all in their own fields were showing how that impacts reading and comprehension. And that's how I came up with a list of executive cognitive functions to test, because even though I'm not diagnosing dyslexia, I needed to know everything that goes into successful reading, whether it was dyslexia or not, to support successful reading. And that was the angle I took. So great question. Oh, Roxanne, you're funny. That's how long it would have taken me. Any other guesses if that 10 to 20 seconds was appropriate or not? I think 10 to 12 seconds is adequate, considering the child may need some of that time to process the question that's being asked. Oh, that's a great explanation. Anybody else want to chime in? I'll give just a few more moments for others to chime in, because this is always a really rich discussion. Okay. Here's my thought process. Typically, educators will say this is plenty of time. Again, they are looking at it from the scope of giving extra time is an appropriate accommodation, and he just needed extra time to double check. Perfect. No worries. Correct answer. Occupational therapists may look at this and say, that's kind of a long time and it's not sustainable. And that's the side that I fall on, because he double checked his work every time he laid a piece down. He should have just taken a few seconds to look back and forth and say, yes, it's complete. What you missed here, I typically don't film children's faces just because of confidentiality, but when I asked the question, the first thing he did was look at me. And the reason he looked at me was because as the provider, he's looking at me to read my body language and to tell him if it's correct or not, and if it's the same. He's relied on that strategy because we've taught them that. You know, we as teachers or educators or therapists or parents, we think we're guiding them. We think we're helping them by telling them and pointing it out, good try. Let's go ahead and do it this way. This is how it's different. But we haven't given them a sustainable skill to do their own analysis. And so he may not have the confidence to make that decision on his own because he hasn't practiced enough to make these decisions on his own. And we've basically done a really good job teaching learned helplessness in that sense. And so in those moments, when I ask students to double check their own work, I specifically will not make eye contact. I'll ask and then I look down because I have the worst poker face and I always give it away. So I try really hard. I can feel their stare like burning in my forehead, but I really want to give them back the power for them to be able to assess their own work. And so that's why it took him time. And I'd like that time to be a little faster so he can keep up with work in school and activities that are going on in the classroom. So that's my take. Most tangrams I have are parts to a whole. I have difficulty myself with whole to part sometimes and love the color code game where the pieces overlap. Yes. Yeah. So this can be a challenge for sure. I think in the resources I gave you, there's a different tangram resource. And I like it a lot because the box is metal and the pieces are magnetic. So you can open up the lid and you can put the pieces on the lid if you want to prevent them from moving around. And the patterns are really big. They're about a 5x7. So they're a lot bigger than these tiny cards. And each shape is a different color. So there may be 3 or 4 colors and they can either build it right on top of that pattern or build it off the pattern. Sometimes the pattern has each individual piece, outlined out, or it's just one big gray pattern. And you have to figure out where it goes, but it grades up and down rather nicely. And I think that's the resource I provided you. But Christina, you bring up a good point. Everyone just learns and processes a little different, and to be aware of that. Very good. Okay. On to the next. Fine tuning. Remember I told you I don't usually pay attention to age and grade when I do an activity, but I will tell you for this particular activity, choose an older child. This is challenging at best, where somebody high functioning in terms of their memory is really close to average, or their memory is average and you're pushing for above average because that's where their IQ is. So basically this can be a visual or an auditory memory activity, and we're giving the directions and they have a grid that they draw on and follow the directions.
Okay. You ready? Okay. So we're going to work on fine tuning. You can use fine tuning activity for either visual memory or auditory memory. And so for training today, I'm going to show you
I want to show you, let's see if I can. Okay, so I don't know if you remember, but the prompt was draw a line from 12 to 27. And it should be a direct line without any other numbers in the process. But I've seen people start at 12 and they've done it this way, where they draw lines all the way across until they get to 27. So depending upon their understanding of the directions, you may want to demonstrate it the first time so they have an understanding of what you're expecting. We have a couple of Q&As. Oh, there was no sound. That is odd. Huh, because I heard the sound. Okay. I'll go ahead and I hope that's not the case for all the videos. Okay. Oh, it's because I muted. Okay. Would you like me to play that again? All right. I'm not getting a response on the Q&A if you'd like me to play this again, but I will play it again because I have a feeling most of it was missed. So I'll start doing that.
So we're going to work on fine tuning. You can use fine tuning activity for either visual memory or auditory memory. And so for training today, I'm going to show you how to do it both visually and then we'll do it auditorily. So for visual memory, you're going to go ahead and you can see on this form where it says primary progression grid 1. So grid 1 should match with a grid in the book, and this is grid 1. So we've paired them up to match. You can either put this in a dry erase paper or you can use it on a regular paper. So first we're going to do visual memory. And so just to start with the very first day, just so they understand how to do this activity, what I'm going to do is cover all the instructions that I'm going to say. Go ahead and read that direction and then go ahead and do it there. So the direction that she's reading to herself says draw a line from 10 to 16. She's going to go ahead and draw that line. Good. And the way to grade this activity up is you can give them more directions to read. So now I'll give an example of reading 2 directions. So you go ahead and read that to yourself. And then you cover it up. And that's the visual memory part, is they cannot go back to it. They have to remember the sequence that they read, the orders that they read. So that's an example of how you can do this from a visual memory perspective. Auditory memory, what you would do is then give the directions verbally. And this is an example. Catherine, I'm going to say direction, and then I'd like you to do it. Draw a line from 12 to 27. Okay. Now I'm going to give you a series of 2 directions. Please wait to draw until I give you the second direction. Draw a line from 10 to 12. Draw a line from 41 to 54. I'm going to give you 3 directions. Please wait till the third direction. Draw a line from 52 to 53. Draw a line from 27 to 33. Draw a line from 53 to 54. Good. And you can see how I graded up the activity by increasing a direction. You'll have instructions on your therapy form if you should give 1 direction, 2 direction, 3 directions, or 4. And that you score this by percentage. So for example, there are 11 prompts on this form. You would divide that by 100, and then you would add up what she got right. And so if she missed 1, it would be divided by 100 is, I think it's 9, 8, yeah, 9. So it'd be 9 times 10 would be 90% if she got 2 wrong, something like that. And that's how you would score it.
Okay, thank you for letting me know that that mute really affected your sound. Whoops. There we go. All right, before we get into auditory memory, well, I'm sorry, we were into auditory. I skipped a part. Let me go back because this is important for us to go over. It's not letting me go there. Hang on. All right, so while I'm fiddling around with this, what I would like you to do is in the Q&A, we just got done talking about visual perceptual skills. We've talked about figure ground, spatial relations, spatial awareness, form constancy, visual closure. What I'd like to have you do in the Q&A, if you will list items that you have either in your classroom, your school, your clinic, that now that you're seeing what we're going after and what we're wanting to do to address visual perceptual skills, what activities do you have that on Monday you could pull off your shelf or pull from your cabinet and use for your kiddos, addressing those visual perceptual skills, knowing you're helping dyslexia that you may not have thought of before, or that you used but didn't know they were really addressing dyslexia. Can you share with me in the Q&A what those are? Because I'd like to share them with everybody and have everybody kind of have a resource of tools that they can grab. So I'll give you just a moment to type in some suggestions of what you have that you think you can use on Monday. Perfection. That's a game, isn't it? Where if you put pieces on, things will pop up. Yes, it is a game. Okay. Are all of you able to see the questions that are posted in the Q&A, or are you not able to see them? You're not able to see them. Okay, so I will continue to say them out loud because I would love for you to write down a list of what everybody is suggesting. Light, bright, perfection. What else do you have? This is a great way to build your resources. Oh, you can see them, Steve. Good. Cartoon it. Leave light, bright, cartoon it, perfection. Any other activities that you have right now in your clinic, your classroom, your school that you could use to address visual perceptual skills? Does anybody have any coloring books or paints or any art activities that you do? Legos. Yes, Legos are great. Magnets.art. Puzzles, connects, puzzles, tangrams, checkers, light, bright, magnets, Legos, magnets.art. So write these suggestions down. Start building your repertoire and learn from each other, because these are all fantastic ideas. And I want you to feel confident on Monday that you have some tools already. So that's another thing I want to bring up. We're in an economy where money is super tight right now. And I know when we go to professional development, we tend to come back really excited and you want to buy everything, or there's things that you want to buy that you learned about. And that is great. But sometimes we just don't have the resources at the time to do that. So taking this moment to reflect on what you already have available can just empower you to dive right in without feeling that you don't have the tools that you need. And then as your budget comes open, you can kind of pick and choose things you would like to get. Various crafts, tangrams, hidden pictures, spot it, mosaic crafts, collage with paper. Love that. Matrix games, geoboards. Geoboards are great for that spatial awareness activity I was showing you, where they copy the design, turn the page, turn the square around, copy the design on the dots. Geoboards are great for that. Connect the dots, jacks, hidden pictures, cup stacking. Yes, these are all great ideas. Good. Okay. I'm going to go ahead and, you know what? I'm not going to delete these. I will leave them here. So as you, as we go through the afternoon and as more people post, you might want to copy down some of the things that they suggested that you didn't think about having, or you may want to add to your wish list of things that you can get for your workspace and for the individuals you work with. Very good. Let's jump ahead. Okay. If you are a speech language pathologist, you're probably very familiar with the HELP series. These are a series of workbooks. They are a little pricey. They are well worth the investment. I use these a ton. What I like about them, there's many things I like about them. One of my favorite things about it, they grade themselves up naturally as you go from page to page, and number 1 to number 2 to number 3, they grade up just so smoothly and automatically. If you're a speech language pathologist, they have IEP goals already written in the books for you to help you along. And they are so, what word am I trying to come up with? They grade up in such small intervals, and they do so much repetition that it is a wonderful way to build a neural pathway. It is a great tool to use that because it does it in such an organic and nice way in terms of how the brain develops. It's a wonderful, wonderful resource. We're just going to cover the HELP series in today's presentation on memory. However, they do have workbooks on phonological awareness and phonological memory and processing skills, word finding skills. I have every single HELP book. I use them all. And so, like I said, today we're just sticking kind of in the wheelhouse of OT, but those other books are also very helpful to have, especially for speech therapy or for teachers and educators. So this is an activity where we are working on auditory memory, and we're working on short-term memory, working memory. So here we go.
So today we're going to be working in a HELP book. We're going to be going to B3, and it's going to be working on auditory memory. So on this part right here, it says page 133. So we're going to go to those. All right, so what you're going to do is you're going to listen to each sentence I read and then answer the question I asked you about what I read. So, I ate a roast beef sandwich for lunch. What did I eat? A sandwich. Okay. And what's your favorite color? Purple. Okay. And what did I eat for lunch again? A sandwich. Okay. The old man waved a stick at me. What did the old man wave? A stick. Mm-hmm. And what's your favorite food? Chicken Alfredo. And what did the old man wave? A stick. Good job. The lamp fell over during the windstorm. When did the lamp fall? During the windstorm. And what's your favorite season? Fall. And when did the lamp fall? During winter. All right, I'll just do one more. The tumble down house had no door and the window had locks but no glass. What did the windows have? Locks. Okay. And what are you doing this summer? Working. And what did the windows have? Locks. Good job. Okay.
Okay, so if you wanted to grade the same activity up for a richer challenge, instead of repeating the question every time, you did the delay, you could just say, what was your answer? Because when you repeat the question, what did he eat? And you do the distraction, what did he eat? You're already prompting them. That's a little bit of a prompt. And so kind of a strategy. So to just say, what was your answer? Now they have to remember what the question was and their answer. And so it just pushes that neural pathway to work a little harder for memory. And we'll just do some more. You can see here we're remembering a series. So the therapist will start by saying the sequence, they'll start repeating it, and then the person will have to say what the last thing is in the sequence. You can see that it starts out relatively easy. Then we get into triple digits. And as you turn the pages, you may get into a longer series. And let's see how this plays out.
Okay, so today we're gonna be working in the Health One book. It's gonna be section D4. And it's gonna be working on auditory memory. So right here it has the page number under the D4 and it's page 126. So for this one, you're gonna listen to each number pattern I say. I will repeat part of the pattern and you'll say the part that I don't say. So for example, 9, 4, 9, 4. Good job. Okay, so we're gonna do 2 through 6. 8, 7, 8, 7. 10, 3, 10, 3. 8, 1, 8, 1. 2, 5, 2, 5. 3, 1, 3, 1. Good job. Okay. And then we'll just do that.
We'll just keep going.
Hello, my name is Zane. Hello. Alan, nice to meet you. Today we're gonna be working on helping memory, what it is, like it says, just helping memory out. What we're gonna do today is I'm gonna give you four things to remember. 2 of them each go together. So for example, the first one, needle, net, thread, fish. Which one of those go together? What do you think? Needle and thread and net and fish. Correct. Okay, we'll go to the next one. Mailbox, butter, letter, bread. Mailbox, letter, butter, and bread. Okay. Sandpaper, salt, pepper, wood. Salt and pepper, sandpaper, and wood. Ring, dog, leash, finger. Dog and leash, ring and finger. Glove, hand, leaves, rake. Glove, hand, leaves, and rake. Over here.
Okay. Now what I'd like you to do is take your notes and your papers and put them away for a minute. Nothing in front of your desk. I am going to show you an activity for visual memory. And it's going to be a tray with objects on it. And I want you to try to use your visual memory to remember how many objects that you're seeing. Now, I'm not there with you, so I don't know if you're doing this, and you may not even be conscious that you're doing this, but many of you are going to say what you see out loud, or you may kind of mumble it or speak it softly. That is using a strategy. So if you do that to remember what you see, then that's a strategy you're using. If you're wanting to build a neural pathway, you can't say things out loud for visual memory if you're trying to build up your visual memory. So just kind of tune into that awareness, like, oh, I'm using a strategy. I didn't even realize that. And I just want you to try to remember as many of the objects as you can see when I turn this over. I'm just getting my timer out. Okay. Here we go. Okay, now write down as many of those objects as you remembered. Okay, add up how many objects you remembered. Okay, in the Q&A, share with me the number that you remembered. Nice. Look at you guys. You're doing pretty good. So the question I have for you is what strategy, if you use the strategy, what strategy did you use? Was it chunking, categorizing, colors? You probably had a strategy that you used. And do you use the same strategy every time you need to remember something? Probably not. So we do this activity for a few reasons. One, to show you that strategies are important and teaching a variety of strategies can be really helpful to your student. And to show you that this is a activity that doesn't cost money to do. Let's say that you're in a school and maybe you're walking by a hallway that has a bulletin board. I know in California, that's kind of tough because a lot of your schools, there are no hallways because every door leads to outside, but you're walking past artwork, or you are walking outside from class to class, you know, from class to the lunchroom with your students, or their classroom to the place you're going to work with them. Stop for a moment, have them look around. What is it that they see? What can they remember? They give you a list, and then you go to your session, or after lunch, you ask them to remember everything they saw. And you'll get an idea of who remembered what in terms of, you know, Johnny remembered 5 things, but now 10 minutes later, he can only remember 1, or everybody's remembering 10 right away, but Sophie only remembered 2. So in your mind, you may think, oh, I may need to come up with activities to help Sophie out, to help build her memory. So these are just some real easy activities that you can do that will help support visual memory. I would encourage you to choose objects that are familiar to the children that you're working with, right? Because they need to know what they are first. So this is what you viewed. So it's kind of just a fun activity. Okay. So again, we still are working on short and long-term memory. And here we go.
I'm going to work on visual memory spatial. So I'm going to show you a row of like letters inside some boxes, and then I'm gonna ask you a question, and then we'll want you to draw them for me. Roll the dice. What is 5 times 7? 35. And can you draw what you just saw, please? Awesome. Let's erase the letters. I'm going to show you the next set of letters, and then I want you to memorize them. Can you roll the dice for me again? What is 5 times 4? 20. And can you draw what you just saw from me, please?
Okay, so this is an activity that you can do visual to kinesthetic, which is what you saw here. You can do visual to oral, where they can say it. You can do it oral to oral, where you as a therapist say the letters and then they say them back. So there's a variety of ways that you can do this depending upon what memory skill you would like to work on.
Today we're going to work on visual memory sequencing. So I'm going to show you 3 letters, and then I want you to say them back to me. And what is capital B, capital Z, capital P? You want to roll that dice for me? What is 0 times 8? 0. And what were the letters? Capital D, capital Z, capital P. And what's your favorite color? Yellow. And what were the letters? Capital D, capital Z, and capital P. And what's your favorite season? Summer. Summer. Awesome. And I'm going to show you the letters. Capital D, capital Z, capital P. Awesome. So now I'm going to show you the next 3 letters. And then what were the letters? Capital O, capital T, capital B. Why will that right? What is 2 times 8? 60. And what were those letters? Capital O, capital T, capital B. And what's your mom's favorite color? Red. And what were the letters? Capital O, capital T, capital B. And what school do you go to? TCC. And what were the letters? Capital O, capital T, and capital B. Awesome. Now I'm going to show you the next 3 letters. And what were the letters? Capital F, capital G, and capital H. You want to roll the dice for me? It's 9 times 9. 81. And what were the letters? G, capital G, capital F, capital H. Awesome. Now I'm just going to show you the next 3 letters. And what are the letters? Capital A, capital C, capital K. And what is your brother's favorite color? Green. And what were the letters? Capital A, capital C, capital K. And what is your favorite food? Mexican food. And what were the letters? Capital A, capital C, capital K. Awesome.
So some of you mentioned Spot It when we talked about visual perceptual skills. And I agree. I think it's great for visual figure ground. It's also great for form constancy, since the shapes of everything on the card are different. I'm going to go ahead and let them start dealing. The other thing I love using this game for is processing speed and visual memory. If you've never played Spot It before, this gives you an opportunity. There's a variety of ways to play the game. And typically you turn a card over. You have to match the card in your hand that has a design on it with the card that's face up. And as soon as you see that match, you put your card down, and the person who gets rid of their deck first wins.
Bullseye. Bullseye. Skull, skull, pencil. Moon. Yin yang. Lock, cat. Snowflake. Bone, bone, bone. Heart. Okay. Round. Yes. Cactus. Dragon. Flower, tree.
So you can see pretty much how the process of the game works. The more people that play, the more fun it is. So you heard me mention earlier that I really value the one-on-one time with the client I'm working with. However, this is one of those great times that it's nice to bring in more people to the activity. So a lot of times, of course, we have more than one child in our clinic. And if this is on another child's treatment plan, we'll just group them all together and we'll all play together. We get pretty competitive. It's a lot of fun. But anyway, it's just an activity that we use for visual memory and for processing speed. However, it is great for figure ground. I lost my train of thought here. Visual discrimination. Oh boy, I need more coffee, I think. Here you go. Let's move on.
Hello, my name is Zane. Hello, I'm Alan. Alan, nice to meet you. All right, today we're gonna play a game of Bop It. What we're gonna be doing is we're gonna be working on some visual memory. Okay, so go ahead and do this. We'll get you started. All right, okay.
The interesting thing about Bop It, depending upon what's going on with your client, this can also encourage them to cross midline if you want them. So they're holding it like this, and some may just use the left for the left controls and the right for the right, but you can have them reach across if that's something you want to do. I've had some interesting responses to Bop It. Sometimes kids can get really frustrated. And again, just meeting them where they are and understanding their frustration. So I was watching a dynamic between one of our clients and one of our teachers that we had, and they were really frustrated. And the teacher kept saying, oh, you can do this. And she was really encouraging him, but they got in this circular conversation where the child kept saying he was frustrated and she kept trying to encourage him, which made me, from an outside observer, realize she was missing where he was and he wasn't feeling seen and heard. So I went over and I knelt down to his eye level, and I told him that I could see that he was pretty frustrated. And he said he hated Bop It. I'm like, okay. And so, he told me it was hard. And I said, I could totally appreciate that. And I said, but here's the thing. I don't care what your score is. I don't care if you just score 1. I just want to see effort. I just want to see what you can do. And it was interesting because as soon as I said that, you could see the weight just come off his shoulder when realizing there wasn't this expectation. And I said, and if we do it tomorrow and you do 2, that's great. If you do 1, that's fine. I said, I just want to see what you got. And then he took it as a real challenge and he ended up playing. And I'm not saying it's always going to be that easy to resolve, but just making sure that the person feels heard and seen and the ability to express themselves can really make a difference. So just like Bop It, Simon can work on auditory and visual memory and processing speed. What's interesting about Simon, though, is it lights up. So if you have somebody working on auditory memory, make sure the lights are on. Because if the lights are off during auditory memory, it's going to light up and the lights will be really pronounced and you don't know if they're using visual memory as much. So just kind of be aware of that nuance. So for those of you not familiar with Simon, here you go.
Go ahead. Okay, today we'll be playing the game Simon. This works on visual memory. And we'll just go by the prompts of the game. And here we go. Start it. Then we'll press green to go. And then the clap will start from there. And that's the count back, which is the number you record.
Okay, this is a good place for us to pause and take our next break. We'll come back in 10 minutes. Again, if you have questions, drop them in the Q&A. Okay, so I hope that answered your questions on the splints. What was the splint? Yeah, we just did that. You are welcome, Erica. Thank you for coming. Oh, Anna, I'm glad this was helpful. Thank you. Kendall, Joe, thank you, thank you, thank you. Julie. Oh, I'm glad this was helpful. Thank all of you for coming. I think I recorded most of the presentation. I think there are spots I may not have recorded. I'm kind of worried about that, but I'm going to upload this on my YouTube channel. So the link is in the email that you received, and you can always go to our YouTube channel for any free webinars. They're all posted there. Okay, I think that is it. I don't see any more questions. I see about 30 more people in the room, but we are done. And have a great day. I'm going to shut recording off.